of Ghana Medical School. She's a fellow of the West African College of Physicians, a fellow of the Ghana College of Physicians. She has a ton of experience in internal medicine, and she's passionate about diabetes care. She had a diabetes training at the University of Virginia in the United States of America. So I'm sure you all agree with me that we couldn't have chosen a better person to chair the occasion than Dr. Henrietta Asari. Ladies and gentlemen, let's give it up for her.
Good afternoon, distinguished guests and members of DEMSoG. It is an honor and a privilege to have been asked by the executive of DEMSoG to chair this meeting. Diabetes mellitus is a global disease. From IDF, 537 million adults aged between 20 to 79 years are living with diabetes. That is 1 in 10. The number is predicted to rise to 643 million by 2030 and 783 million by 2045. Over 3 to 4 adults with diabetes live in low and middle income countries, and that includes us. So it's important for us to know how to diagnose and treat the complications before they arise. Diabetes was responsible for 6 to 7 million deaths in 2021, 1 every 5 seconds. In Africa, 1 in 22 adults are living with diabetes. The total number of people with diabetes is predicted to increase by 129% to 55 million by 2025. Over 1 in 2, that is 54% of people living with diabetes are undiagnosed. Diabetes was responsible for 416,000 deaths in 2021. Diabetic patients are up to 3 times more likely to develop cardiovascular disease. And a third of people with diabetes will develop some form of vision loss during their lifetime. About 93 million people worldwide have some form of diabetic retinopathy. Kidney failure is 10 times more common in people with diabetes. A lower limb is lost to diabetes somewhere in the world every 30 seconds. The situation in Ghana. In 2002, Prof. Albert Amwa found a prevalence of 6.3% of diabetes in 4,733 patients. In the year 2019, Dr. Osei Safo Kantaka found a prevalence of 6.46. The topics to be discussed this afternoon will improve our management of diabetic patients and prevent complications. The third topic, mental health challenges in diabetes, is very appropriate because to some patients, a diagnosis of diabetes is like a death sentence. So, colleagues and everybody listening, either present or online, you're welcome to the 5th Annual Scientific General Meeting of DEMSoG. Thank you.
Thank you very much, Madam Chair. May I make these few announcements? So for our online participants, if you have any questions or comments, kindly put it in the Q&A box. We would read it at the appropriate time. So I'm sure we would start with the first presentation. Madam Chair, so the first person will be speaking about acute complications of diabetes, prevention, diagnosis, and management. Oh, sorry. Okay, very sorry. So we would have our sponsors presentation right about now, and we would invite a rep from BI, Boringa Engelham. So the BI rep, ably represented by our vice president has become a farmer person. Thank you very much, both of you.
Thank you. Yes, So I'm doing this presentation on behalf of BI. And please, can you switch the slides, please? Can you go back? Speed up a bit so that we can cover enough ground. Contribution that so the light numbers, what it does as well is affecting a lot of people and causes heart failure as a result, and cardiovascular deaths. And then CKD is the most common reason for progression to end-stage kidney disease in many parts of the world. So it's causing, yes, there's increase in the numbers, associated morbidity and mortality, but as a result of the combination of all these factors is the increase and the impact of the condition and associated complications on the healthcare budget of nations, especially for us in Africa where there is meager resources and these austere times that we find ourselves. That is something that is not good for us. Again, this is emphasizing the same points that have been made, emphasizing the contribution of diabetes to CKD portfolio. Next important cause is hypertension. Again, among the elderly, they tend to die more if they have CKD, and they also tend to progress faster to end-stage kidney disease and also to have renal replacement therapy. Okay, so this is just a sneak peek of the nephron, which is the functional unit of the kidney, and this is the glomerulus, and this is the ducts, and then the ascending loop and the descending loops. So this is the seat of the problem where diabetes affects the kidney and it results in decreased renal function and proteinuria, which is a major aspect that we tend to overlook. We always talk about EGFR and leave the albuminuria. So the next few slides will emphasize the role of albuminuria, why we should be screening our patients for proteinuria as well. And how do you measure proteinuria? The best tool is to do a 24-hour urinary collection, but this is cumbersome. If they give you a bowl to take home, to wee in it for the whole 24 hours and bring it back, many people don't like that. So the more practical way is to do a spot urine test doing the urine albumin creatinine ratio. Though it is the most practical, it also has its downsides. It's affected heavily by the creatinine excretion, and there's a lot of intra and inter-individual variability. And then its reliability would depend on the amount of protein that is excreted. If it's around 1 gram, then you can absolutely rely on it. Again, even within the same day, there's variability in terms of the amount of proteins that are excreted. Nonetheless, it remains the most practical tool to use to assess proteinuria. And this point I've made already, that we tend to focus on EGFR, but the protein excretion is important. So if you superimpose the two, EGFR and the protein, you realize that as the amount of protein excretion increases and the EGFR, also increases, it pushes the person risk higher. So it's recommended that those in stage 3 with proteinuria should be referred to see a nephrologist. And anybody certainly in stage 4 and 5 should do that. But if you just did only EGFR, you probably would delay their referral and lead to more complications for the patient. So how do we generally manage patients with CKD due to diabetes? So this is looking at type 2 diabetes in general, and this is a consensus statement by the AD and the EASD. EASD is European Association for the Study of Diabetes. And the new approach is to risk stratify or classify the patient and decide which therapy is best suited for the patient. So those with atherosclerotic cardiovascular disease or those who are thought to be high risk, it is recommended that you give a GLP-1 analog, with proven CVD benefits, or an SGLT2 inhibitor with proven CVD benefits. If your person has heart failure predominant, then SGLT2 inhibitors are your best bet. If CKD predominates, SGLT2 again are your best bet, especially when EGFR is greater than 20. If it cannot be tolerated or unavailable, you can use a GLP-1. So let's look at what the kidney guidelines also say. It's similar. Lifestyle measures, certainly for all forms of chronic illnesses, is a backbone. But what agents do they recommend as first line for the management of patients with diabetes and CKD? Certainly your SGLT2 comes there, metformin, statin, and then RAS blockage. Take note of the RAS blockade. We'll come to that when we look at the EMPA-REG study. And so certainly it's one of the considerations, after your lifestyle changes. And then for a lot of these patients, they may also benefit from statin therapy. When do you use metformin? The recommendation from the kidney guidelines is to start metformin if your EGFR is above 30, okay? And then you continue until they start dialysis or they do transplant. And then certainly if it's below 30, then you can consider other agents. What about SGLT2? Recommended to be started when EGFR is less than 20. So the recommendation says that if the person has type 2 diabetes, CKD, and EGFR greater than 20, you should treat with SGLT2 inhibitors. And then, if individuals are already being treated with other glucose-lowering agents and SGLT2 can be added to the current treatment, and it must be continued until they start dialysis or a transplant. So quickly go to the EMPA-REG study that looked at how empagliflozin would affect kidney disease and kidney progression. So this was done in 8 countries across the world, mainly in Asia and Europe. And what they looked at was a primary composite endpoint, which I'll come to that later. But they stratified the patients over 6,000 into 2. The first arm were given 10 milligrams of empagliflozin versus the control arm on placebo, and the median follow-up period was 2 years. And these were the baseline characteristics. 54 did not have any history of diabetes, 27 had some form of CVD, EGFR less than 30 was in 35% of them, 48% had albuminuria less than 300 milligrams. And these were the causes of the kidney disease in the patient. Diabetes again predominated. So what was the primary outcome? It was a composite of kidney progression and CVD or all CVD death. And clearly there's a separation with statistically significant difference. So clearly those on EMPA benefited in terms of these 2 composite endpoints. And then if you separate those ones out, the CVD there didn't show any significant difference. However, the kidney progression maintained. So it means that the driver of the composite endpoint that you were seeing was mainly due to the kidney progression. Now, what about some secondary endpoints? This is all-cause hospitalization. Again, those on empagliflozin did better than those on placebo. The heart failure or CVD death, first adjudicated heart failure or CVD death, did not show any difference. And then all-cause mortality also did not show any difference. So if you summarize the key findings, the primary or composite primary outcome was achieved. The other CVD death or kidney progression was achieved. The secondary endpoint, all-cause hospitalization, either the first or recurrent, was also achieved. The rest did not meet statistical significance. And some little drilling down, you see that those who had diabetes benefited more than those who didn't have. Again, irrespective of the baseline EGFR, there was benefit. Okay, and the proteinuria as well, it benefited more of those who had heavy proteinuria. And remember this, irrespective of the glucose control, there was benefits. And then those on RAS, I told you to take note of those on ACE inhibitor or ARB. They definitely benefited more than those who were not. And those on prior cardiovascular disease, but it didn't matter whether you have prior cardiovascular disease or not, there was benefit compared to those on placebo. The annual change in EGFR again showed clearly benefit to those who were on empagliflozin, as well as the mean observed drop in EGFR. What about safety? Patients, the numbers were quite close. The p-values were not indicated, but they were quite close. And reason for discontinuing randomized treatment, the serious adverse event, clearly in favor of EMPA and non-serious adverse event. Again, at this time in favor of placebo, but it would have been good to have seen the p-values. Slide not moving. Technical people, the slide is not moving. Okay, so the other safety outcomes were also comparable, both the UTI, genital infections, and other parameters that were analyzed. So to summarize, what I've tried to tell you in this short time is that kidney disease is becoming increasingly frequent in patients with type 2. But the result of that is that it's reducing life expectancy and also associated higher CVD mortalities. And again, for us in Africa, cost is an issue. Okay, and I just drew your mind, to the fact that it's not just EGFR, but the proteinuria is important, that must be assessed, because once there's proteinuria, the outcome is a bit is worse than if you didn't have. And to summarize the treatment modalities, it talks about lifestyle. And those on RAS blockade, remember, in the EMPA kidney, they did better than those who were not. So somehow it tells you that, well, you should, put a person on RAS probably before SGLT2. And that's a recommendation by ESD and ADA as well. The others can be chosen and added as appropriate. Remember your starting therapy, for a lot of them, their cardiovascular burden is high, and they would benefit from statins as well. So this is the end of my talk. Thank you very much.
Thank you, Prof. All questions will be asked at the end of the presentation. So if you have questions, just jot them down. I'm sure you want to know the cost of the medicine, so you can. And unfortunately, I hear online attendees are having problems, so it's been sorted. But when it's sorted out online, please type your questions and they will be answered appropriately. Our next presentation. Okay. So the online people are being given a new link, so please, 5 minutes. So in the meantime, those of us here, if you have a question for Prof. York about the medicine he presented, you can ask him. So we can save time. Anybody? Any of you had any experience with using the medication? No questions. Okay. So we should give the online people. They are getting a new link.
Great. A pleasant good afternoon to you all. BI is excited to partner with DEMSoG for this AGM. For the cost, the current wholesale price for empagliflozin is 580 Ghana cedis from our leading wholesalers. The retail would vary between 700 and 800, depending on where you're getting it from. But our approach now is to use market access to get these products into different, institutions where we know there are a lot of these diabetics with, different complications, so that then we can have it even lower than the wholesale price. So I think that the price question is always a tricky one, but we want to emphasize the overall value of the medication you're getting in terms of dealing with, preventing complications, CKD, etc. Thank you. And thank you, Dr. York, on behalf of BI. Cheers.
Online, are you with us? Okay. A link has been provided. Our next presentation is acute complications of diabetes. And we're going to hear from Dr. Henrietta Fission. Dr. Fission is a consultant physician specialist diabetes and endocrinologist at the Greater Accra Regional Hospital. She's a product of the Hospital of the University of Ghana Medical School. She obtained her fellowship in diabetes and endocrinology from the West African College of Physicians. She also holds a postgraduate diploma in endocrinology from the University of South Wales, Cardiff, United Kingdom. She has several years of experience in diabetes care and has research interest in thyroid diseases. She's actively involved in the training of medical students, residents in internal medicine and endocrinology. She has actively been involved in several continuous education programs in diabetes and endocrinology. Let's welcome Dr. Henrietta Fission.
Hello. All right, so thank you very much, Dr. Asari. So good afternoon to you. Okay, so just a moment. The wrong one has been projected. Anyway, so thank you all. Thank you, Chairman, for that kind introduction. Our Chairman and Prof. York has given us a bit of epidemiological studies, so I'm going to go straight to my presentation. And this afternoon, I'll be looking at 3 important conditions that constitute the acute complications of diabetes, which we'll see in our practice a lot. Try to highlight the important areas for us to take home so that we can improve the care of our patients. So the 3 conditions I'll be talking about this evening is acute complications of diabetes, which includes diabetic ketoacidosis, hyperosmolar hyperglycemic state, and then hypoglycemia. And this will be the outline of my presentation. So as a way of introduction, diabetic ketoacidosis, which is DK, is a severely uncontrolled diabetes which is associated with ketoacidosis that requires emergency treatment with both insulin and fluids, as well as correcting the metabolic derangement that occurs. And it's an emergency that requires immediate treatment. Unfortunately, in our practices, we've had a few delays. People go around before they come, and if you don't manage it within the shortest possible time, mortality tends to be high. And during the management or as part of the disease process, it's associated with cerebral edema, life-threatening conditions, and acute respiratory distress syndrome, which we need to pay attention to. Now, the management involves a multidisciplinary approach, so it's not just about bringing down the sugar, but you need to correct fluids, correct all the metabolic derangements, as well as preventing subsequent complications. Now, in DK, biochemically, what you will see is metabolic acidosis, which is evidenced by the reduced bicarbonate levels, there's hyperglycemia, ketonemia, ketonuria, increased anion gap, and accompanied by fluid depletion and electrolyte abnormalities. Now, DK is more common in our type 1 diabetics, but you would also find it in some type 2 diabetics. So that's just a brief summary of what actually occurs during the whole process. And so because of the insulin deficiency that occurs, you have increase in your counter-regulatory hormones, which includes your cortisol, growth hormone, and epinephrines, glucagon, which further worsen the whole cycle. So key in the pathological process is stimulation of hepatic glucose production, and then there's stimulation of fat lipolysis that further leads to production of free fatty acids and glycerol, as well as general inhibition of glucose utilization in both at the periphery and at the fat level, leading eventually to hyperglycemia. And in addition, you have production of ketone bodies that leads to the ketosis and contributes to the decay. So what happens during the whole time is that you have your glucose concentration going up. As a result, you have increased osmolality, and it increases or creates a gradient that draws water out of the cells. But initially, your glomerular filtration is increased. So what happens is that all this glucose is going to lead to glycosuria and osmotic diuresis. But when this goes on for a while, because of your hypovolemia that occurs, you have reduced glomerular filtration rate, and as a result, then you are going to have progressive decline and then worsening of the hyperglycemia and ketosis. Now, how do we define HHS? So it is a syndrome which is characterized by severe hyperglycemia, hyposmolality, and dehydration in the absence of ketosis. And the exact incidence is not really known. It's thought to account for less than 1% of hospital admissions. Now, mortality rates can be high in those individuals whom you make that diagnosis compared to those you come with decay. Now, the prognosis is usually dependent on the severity of the dehydration and the presence of comorbidities. You know, most of our patients will come in with underlying other conditions. So you have your patient, elderly patient who has probably come with HHS, has kidney problems, has heart failure, and those are the things that eventually affect your outcomes. And so the treatment also in HHS is directed at replacing the extreme volumes of fluid which the patients lose. You correct the hyperglycemia as well as the other metabolic derangements that occur. So in HHS, what usually happens is that you have marked hyperglycemia, and then you have increased serum osmolarity. However, because of the relative insulin deficiency or the presence of some amount of insulin, you do not have significant ketone production. And so we don't tend to get acidosis. So what are the precipitants? It's the same for both conditions. Maybe infections from your UTI, and especially in our environment, the skin and soft tissue infections are really quite common. So the abscesses and all the bacterial infections that they get, which also be as a result of non-compliance, inadequate insulin injection. And sometimes it will amaze you, for those who are on insulin, they do all sorts of things. So when they sit in front of you in the clinic, you need to take your time to talk to them. There was a woman I saw who came in. She'll come and sit. She'll bring what was a chart. But the whole period, the woman was not injecting the insulin until she came on admission, and she admitted that, "Doctor, sometimes I'm totally lost. I don't know what to do. I can't inject the insulin." Meanwhile, this is somebody that you take your time and speak to and ask, "Let me see your profiles. Are you injecting?" And they will say yes. So it's very difficult. Some of them will tell you they don't have money. My insulin is on insurance, but you still get all sorts of excuses. So we really need to take our time to ensure or improve compliance in our patients. Then other systemic diseases, they come with strokes, MIs, it may predispose them to getting an HHS. And then in minority of those people, you will find no obvious cause. So the typical history is the same: polyuria, polydipsia. They may have weight loss in an undiagnosed patient or somebody who is poorly controlled. Then they may come in with vomiting and abdominal pain, especially in our DKAs. And then they may become confused and obtunded. An examination, you may find presentations from the underlying associated disease condition. You may be febrile, dehydrated. In the DKA, they may have Kussmaul's breathing and abdominal tenderness. They are confused with altered sensorium. Some of them may actually come with seizures, and it's actually very common in HHS. So what is the diagnostic criteria for DKA? So usually there's ketonemia, ketonuria of more than 2 pluses, so 2 pluses in the urine, but ketonemia more in the blood. There are ketone meters we are able to use. Some people are able to assay the actual ketones, hyperglycemia of more than 13.9. And then the evidence of metabolic acidosis is when you have a pH of less than 7.3 and a bicarbonate of less than 18. Then you have an increased anion gap. How about HHS? So the current diagnostic criteria is to have a plasma glucose of more than 33.3, and effectively it gives you a plasma osmolarity of more than 320 and absence of significant ketosis. So in the workup of our patients, these are some of the things that we want to do. Initially, because they might come in quite unwell, you have your initial assessment, trying to stabilize them, whether in terms of their blood pressure, their respiration, temperature, and all, and getting them stable whilst you do your labs. So these are some of the things that you'll find. Of course, there's increased glucose. Then you may have reduced bicarbonate, increased anion gap, and then other changes. So because of the initial period of reduced perfusion from the dehydration, you may have abnormal BUE or your electrolytes, which may correct if it's an acute condition. But some of them may have a background of kidney disease, especially in our type 2 diabetics, or even in your type 1. And you may have potassium because of the shift in the electrolytes from the severe dehydration and reduced sodium. And then, of course, you find urinalysis. Your urinalysis will show evidence of ketones. And then what else will you do? We need to do a septic screen, whether your blood cultures, urine cultures, arterial blood gases. It's a bit difficult. It's not everybody who may have the opportunity to do the arterial blood gas, depending on where you find yourself. But there are general principles that you can follow. It is good to do your blood gases. Sometimes when you do a BUE, you may have your bicarbonate result and to give you or tell you what is going on. And then because of the abdominal pain, a differential of pancreatitis, but the thing is that even in your DKAs, you may have your amylase lipase going up. And then you need to treat for underlying, screen for the other conditions. So sometimes, as I said, the systemic illness is actually what is going to tip them into either the HHS or the DKA. And so typically, you may have them, maybe they may have heart failure, they may come in with a stroke, other comorbid conditions that you need to manage. So what this table is showing is trying to differentiate between DKA and HHS and also categorize your DKA into mild, moderate, and severe. And so that is what is showing on the table or on the screen. So for all of them in DKA, plasma glucose is more than 14, in HHS is significantly raised, more than 33. And then the pH is another one that will help you. So in HHS, usually pH remains normal. By severe DKA, it goes below 7. And then moderate is between 7 to 7.24. In that order, bicarbonate, severe DKA is less than 10. Moderate is between 10 to less than 15, and then in mild is 15 to 18, plus the other parameters as you have seen. The mental state, usually with the mild one, they tend to be alert, but for the moderate or the severe, they may actually have reduced level of consciousness and go into stupor. So the principles of management is fluid therapy, insulin therapy, and treating the underlying conditions, and then the long-term management of the patient. So usually for DK, we say that the patient would have lost about 10% of their body weight. So their goal is to expand both the intra and extravascular volume. So within the first few hours, you want to try and replace at least 50% of that deficit, and then you have the remaining 24 hours. Remember that our patients also come in with comorbid conditions. You need to pay attention to make sure they are not going to overload them with fluid. So usually you can give about 15 to 20 mils per kilogram per hour within the first hour, which is equivalent to a liter. In the next 2 hours, you do another liter, and then in that manner. However, in HHS, which usually have severe or more severe dehydration, it is said that you lose about 10 to 20% of your body weight. And so fluid replacement is very, very important. And one thing about HHS is that, remember we said the plasma glucose is usually more than 33. And then the plasma osmolality is also very high. And so usually before we initiate insulin therapy, we would like to start rehydration, at least a liter, to increase perfusion. Because remember that sometimes we are giving the initial insulin as IM. That's a different form of regimen. But it's also important that we hydrate at least 1 liter before we start the insulin therapy in HHS. And then once you have done that, then you can begin. Sometimes our patients, when they come in because of dehydration, they may come in with a hypernatremia or a hyponatremia. And so as you correct, and the patient has hypernatremia, they need to consider using half strength of, the fluid. Using half strength of saline, sorry. Now, the recommended thing for us to do is give soluble insulin during the management of our DKs. And, in the past, we are still doing it, but it is better give the insulin as a continuous infusion. And so usually what we do is that, sometimes we say, okay, let's give IM soluble insulin 10 units start. Then every hour you'll be monitoring and you'll be giving 5 and be topping. But we prefer to give the insulin continuously using a dose of 0.1 units per kilogram per hour. And so let me make it very simple. One of the ways, it's not everybody who has perfusers, but you can also use your dorsiflow, and it's working perfectly. So the easiest to learn it is that if you have a 70 kilogram and male or female, it means that you are going to give about 7 units per hour. If the person weighs 85, you are going to give about 8.5 units per hour. If the person weighs 90, it's going to be 9 units. So it's very easy if you can estimate the weight. Sometimes the patients are quite ill, they don't know their weight, so you will just do a rough estimate to guide. And so we give that kilogram per hour. We give that using the perfume, but we're also able to use the dorsiflow. And then once you do that, you are going to monitor the sugar every hour, and you are aiming to drop it about 4 millimoles per hour. Now, when the sugar drops to less than 13, so with the above therapy, you are using normal saline. When the sugar drops to less than 13, now you are going to give half of that amount, which is 0.05 units per kilogram per hour. So what it means is that you started with a 70 kilogram rough estimate, you are giving 7 units per hour. We're just going to reduce it to half, which is 3.5 when the sugar drops. It becomes very easy for everyone to use. The House of Cells are confident and they are all doing it. And then we switch to dextrosaline once the sugar drops to 13. Alternatively, You remember we all use what we call the modified diabetes regimen, which the initial insulin is given as an IV or an IM, and the sugar is 3 hour, and then when it drops to 13, then we change to subcut and we move all the sliding scale. So this is the sliding scale that we all know. How do we manage the acidosis? Usually you see that this is for DKA. You see that once you start insulin therapy and you start your IV fluids, the acidosis will usually correct unless there is severe acidosis. And I'm going to show you my table on the next page on when the pH is less than 7. And so we give bicarbonate. How do we manage hyperkalemia? It's important to try and get an initial BUE as quickly as possible to have a rough estimate of what your potassium looks like. You know, we used to say that once the patient is passing urine at least 30 mils per hour, it's safe to even start maintenance potassium. But it is important to check your potassium levels because we've been shocked at sometimes the levels of potassium that we get. And so it is always important to get potassium before you think of replacement. Hyperkalemia will occur because of severe dehydration and is likely to correct. And once the patient has started passing urine, you may do your maintenance potassium. So when you have hypokalemia, you are going to do about 40 millimoles in a liter of IV fluids. Normal kalemia, the maintenance is about 60 millimoles a day. But in severe hypokalemia, we actually need to calculate the potassium deficit so that we can do the correction properly. So this is just a table trying to show how we give bicarbonate. And as I said, when the pH is less than, that is when you might actually have to give bicarbonate. But remember that close is given bicarbonate. Usually these are patients who are very unwell. We have to manage them in either HDU or an ICU. It is not everybody who has an ICU, but close monitoring is very key. At your level, when it gets to where it is difficult, you have to refer. But patient outcomes and prognosis is far better when you manage them properly in a high dependency unit. Why do I say that? Because remember I said that you may have DKA in a child or a young person, not even a young person. It could even be somebody in their teenagers and somebody who is a teenager or even a young adult. Because really, as we say, until the person is about 40, you can never really tell as type 1 or type 2. When it's type 2, usually we can say that confidently above the age of 40. But below 40, from childhood to your 33 or 35-year-old could still be a type 1. So it is important for us to try and find out which one by doing the C-peptide. But you never go wrong in putting the patient on insulin. So continuous monitoring, as I said, is very important in those who may already have some underlying fluid overload from kidney disease or heart failure. They monitor for complications. And some of them are cerebral edema, acute respiratory distress syndrome, thromboembolic events. And so in patients who have HHS, remember that their plasma glucose is more than 33, and then the plasma osmolality is also very high. And so they have increased risk of thrombotic events. And so you will need to anticoagulate them. How can you tell that patient is getting better? There's resolution. So once your glucose, excuse me. So how do you tell that? How do you tell that your patient is getting better? So straight away, these are the things that will point to the sugar starts dropping to less than 11. Your bicarbonate corrects, and then the pH now comes back to normal, and then the urine ketones become absent. Now bear in mind that correction of the urine ketones become normal in the blood faster than the urine. So sometimes your patient may actually be out of ketosis, but then the urine ketones may still be present. So how can you tell? A patient who comes with DKA was vomiting, having abdominal pain. Now the patient is better, patient is talking, can eat without vomiting. Then you know that ketones have actually cleared in the circulation because the urine ketones lag behind the blood ketones. So long-term management, what do we do? In your patient who has type 1 diabetes, the patient is already on insulin and will continue on the insulin. If they defaulted, you need to reinitiate it. What about your types? And there are different ways of giving the insulin. We have the biphasic insulins, which is the mixed that we all know. And then we have what we call the basal bolus regimen. And the basal bolus is the mealtime or prandial insulin injections using the rapid insulins with a basal insulin at night. And initially we prefer that for our type 1s because it mimics the normal the response of insulin to our mealtime. The mixed also works for the type 1s. But if you have a patient who is not doing well on the mixed, probably need to review the type of insulin that you are using. And then you also need somebody who will be motivated to do it because there's no point in giving somebody injections when they are not going to do what you are telling them. And so those are the different types of insulin. And usually what we do is that you do an average of the amount of insulin that they need using the weight. You could do about 0.5 units, 0.5 per kg, and then you split it 2/3 in the morning, 1/3 in the morning. If you in the evening, sorry, if you were using sliding scale, you have your average of 3 days, which you take the 2/3 and then another 2/3 in the morning and then in the evening. When it comes to the basal bolus insulin, it's still this slightly different but quite easy. So it's 0.5 units per kg. So let's say if you have an 80 kilogram person, 0.5 of that is 40. And then you divide it into 2 there. So 40, so now you have 20, 20. So 20 as your basal insulin. And then you split the other 20 into the 3 doses, which you will give to your patient. Now you're aiming at a glucose of 7 to 10. Usually around 9 to 10, because remember that whilst in the hospital, they are just lying down, not doing much. And the moment they get home, they are going to become active. They are going to start walking around and doing what they were not able to do. And so you see that their glucose levels will go down further. So you don't want to keep their glucose around 5 to 6. Otherwise, you are going to cause hypoglycemia. And one thing I also like to mention is that usually, as I said, your type 1 diabetic who comes with a DK, what you need to ask yourself is that what actually tipped that patient into a DKA? Was it from non-compliance or a concurrent illness? And so you can review the doses. What about your type 2 who came with a DKA? You may have type 2s who come in with a DKA, but that's a very small amount of the population or small amount of the patients. Probably from poor compliance or the fact that, as we know, diabetes is a progressive disease, and so sometimes the orals don't work and you need to step up management. Now, if you have a newly diagnosed diabetic who has come in with a DKA, usually we say that within the first month or 2, because of the continuous high levels of glucose, there's some evidence of glucotoxicity. So usually the insulin helps them to recover during the first 2 months. So if it's your newly diagnosed diabetic who came in with a DKA, you want to give insulin for a while before you now start your orals. But if it's your type 1 diabetic, then you need to intensify your treatment and find out why the patient went into DKA. All right. So signs of bad prognosis are these extremes of age. So very young person or an elderly person, when they have altered sensorium, severe acidosis and hypothermia. So I'll move on to hypoglycemia. So these are episodes of very low glucose levels. This is a definition from the ADA work group. And I must say that hypoglycemia is more dangerous. Both of them are not good, but hypoglycemia can kill your patient very quickly without you being able to do much. So as much as possible, we want to try and prevent these episodes of low sugar. And so it becomes difficult to state which glucose concentration actually would Hello. Okay. So usually individuals who don't have diabetes, they get a low or hypoglycemia symptoms with a glucose level of 2.8 to 0.1. And the threshold for these symptoms usually shift. So for example, in individuals who have tight glucose control in your diabetic, they have lower thresholds. So what it means is that in somebody whose glucose is well controlled, they develop symptoms of hypoglycemia at a much lower value than somebody who has high glucose concentrations in a poorly controlled diabetic. So what happens is that somebody who has high glucose levels for some time, let's say you're poorly controlled, you've altered their medications and now their sugar is getting better. Because they've been exposed to high levels of glucose for a while, when you start bringing down the sugar, then they tell you that they are having symptoms of hypoglycemia. And our patients will come and tell it's low, but it must be documented. So at times that they felt those symptoms, they must actually check the sugar. Sometimes it's in the night, they are asleep or maybe sleepy, so they are not able to check. But symptoms of hypoglycemia, for it to be actually say that it is hypo, they must at least have documented evidence. And so that's what we call the Whipple's chart that helps us to make that diagnosis. So what it is that you must have low plasma glucose, you may have symptoms pointing to it, and then those symptoms should reverse once you've corrected the hypoglycemia. And the symptoms are usually autonomic or neurogenic and neuroglycopenic. So what the body tries to do as its way of response when your sugar goes low, first of all, my first slide, so the first column, insulin secretion will begin to go down, glucagon, which is a counter-regulatory hormone, will begin to go up, and then your parasympathetic system is stimulated. The other counter-regulatory hormones will still also go up. So cortisol will go up. So this is glucose level of 3.6 to 3.9. And then the symptoms becomes even worse by the time the sugar gets to 2.8. And once it is less than that, then there's impaired cognition. So this is just a table showing the various responses in your diabetic type 1 or early type 2. So what I want us to know is that after several years of diabetes, both in type 1 and type 2, their parasympathetic response or sympathetic response is attenuated. So they will not get all the typical signs of the hypoglycemia. So they get what we call a hypoglycemic unawareness, which I'll describe. So these are some of the signs. There's palpitations, sweating, hunger, and then the patient feels weak. So these are the other things that you see. They have tiredness, weakness when the sugar is less than 3, and then cognitive dysfunction. So some of the patients, you'll be shocked. The patients who have become very aggressive have also been because of very low sugars. Now, severe hypoglycemia, usually the patient is unable to treat themselves. So this is the classification of hypoglycemia. So with those sugar range, this is mild, moderate, and then severe when it is less than 2.2. So I want to emphasize on this one quickly. So in severe hypoglycemia, usually the patient must be assisted to either be given resuscitative fluids or glucagon or a carbohydrate. So human symptomatic hypoglycemia means that the patient had a symptom, they checked and it was present. And in asymptomatic hypoglycemia, the sugar was low, but then the patient did not have symptoms. Probable means that the patient had symptoms which was typical of hypoglycemia, but they did not check. And so that's why I say encourage them to check. And relative means that even though the sugar was greater than 3.9, they still had symptoms. So let me just skip this one and go to the risk test for hypoglycemia. So missed meals, following alcohol injection, and then increased utilization of glucose, which is usually after exercise, and then excessive or insulin secretagogue. So that's sulfonylureas typically. Then when insulin clearance is reduced in kidney disease, and then increased sensitivity following weight loss or improved glycemic control, and then hypoglycemia from autonomic failure. The other causes are patients with kidney disease, liver disease, sepsis. Sometimes on the ward realize that their sugar begins to go down. And then some endocrine conditions with cortisol, growth hormone deficiencies, they develop hypoglycemia, non-islet cell tumor. So these are causes of hypoglycemia in non-diabetic patients. So in your seemingly well patient who is having repeated episodes of hypo, these are some of the conditions that predispose them to it. Either it's an insulinoma or post-surgery, or they may have developed insulin antibodies. So the investigations include checking your kidney function, liver disease, making sure that they are not overdosing medication. Because sometimes when we change medication, upon taking the medications together, when they come to the clinics, the medicines, because sometimes they take different brands of the same medication, and then we check our fasting plasma levels. So what else? How do we treat? For mild to moderate hypoglycemia, usually is self-treated by getting them to just take a juice or a soft drink. Moderate, after the drink, they have to take in a complex carbohydrate which will delay gastric emptying so that the hypoglycemia is not prolonged. And usually there's improvement within a short while. And then sometimes they also have to take in more substantial snacks. But in severe hypoglycemia, then this is be assisted. And usually they are given, one thing we can use is glucagon, but unfortunately it's not. We had a type 1 who had it in her bag, but for a long time now it's not available. And there's no use using glucagon if there are no glycogen stores. And so what we will typically do in severe hypoglycemia in the hospital is where we give 50 mils or 50% dextrose, and then we follow up with infusions. So the treatment usually depends on the extent of the hypoglycemia and then monitoring and trying to identify what has predisposed to the hypoglycemia. And so things about eating right, eating regularly, and not skipping meals and yet taking medications, adjusting doses during exercises, especially for our type 1 patients. When they need to exercise, what do we tell them? They need to have a snack in between as they exercise so that they don't develop hypoglycemia. And these are the complications of hypo. As I said, it is more or it is worse than your hyperglycemia and will kill your patients. You need to reduce all those risk factors. And so diabetes self-management is very important. You need to encourage them to monitor their glucose, to eat regularly and appropriately, and then to give appropriate doses of the medications that they are on. And then achieving glycemic targets. You can't tell, how should I say, 70-year-old who has disease, heart disease, you want her fasting sugar to be 5. It's the same 40-year-old who has diabetes and is very healthy. So your targets should be individualized, looking at the age of the patient as well as the comorbid condition. And then you need to evaluate their medications. So thank you very much for your attention.
Thank you, Dr. Fishin. If you have questions, please note them down. Our next presentation is by AstraZeneca.
Hello? Okay. So good afternoon, everybody. Good afternoon, everybody. My name is Graham from AstraZeneca, and today we'll be looking at the role of Forxiga beyond HbA1c control. So International Diabetes Federation recorded 537 million people living with diabetes, and it's predicted to have a 46% increase to 784 million people by 2045. And if we zoom into Africa, you can see that as at 2021, we recorded 24 million people, and it's expected to go up to 55 million by 2045. 15 minutes, sure. I have 15 minutes, so I have to be fast. So we all know we've gone through these ones. So for patients with type 2 diabetes, heart failure and CKD are the most earliest complications that we have. And studies have shown that 60% of these patients develop these complications. And Forxiga is not only superior in terms of HbA1c reduction, but has additional benefit of weight loss and BP control. And we just look at two major studies that show this benefit. So the first one will be the NUAC del Prato, where we compared Forxiga as add-on to glypeside, which is an SU. We look at the primary endpoint, which is change in HbA1c. The secondary endpoint is change in body weight after 52 weeks and beyond. And then the additional endpoint will be change of systolic BP. So if you look at the chart, so this has to do with the change in HbA1c from 0 to 52 weeks. You can see that when you compare Forxiga as add-on to our SUs, it's non-inferior. But when you go beyond 52 weeks, you can see the durability of Forxiga. So the Forxiga arm is the graph, which is a bit deeper. And then the lighter one is your metformin plus your glypeside. Okay. So you can see the durability in HbA1c reduction with Forxiga, which was consistent from 0 all the way to 208 weeks. Same for the change in body weight. Of course, when you are on Forxiga plus metformin, you are going to see a significant change in body weight compared to metformin plus your sulfonylurea. And then also we have some systolic BP reduction as well, mainly because of the mechanism of action of Forxiga. You have some form of osmotic diuresis going on aside the reduction or the removal of glucose from one point to the other. This is another study which compared Forxiga as add-on to metformin against sazagliptin, which is a DPP-4. And you can see that from 0 to 24 weeks, there was greater HbA1c reduction with your metformin plus your dapagliflozin compared to your metformin and your sazagliptin, which is your DPP-4. So we are, aside these benefits, Forxiga also offers cardiorenal protection. And we'll be looking at the studies that have shown these benefits as well. So the first one will be the DECLARE study. Now, in the case of Avandia, which is rosiglitazone, it was an excellent antidiabetic until, after the long use of these products, we saw that patients came up with a lot of complications. So US FDA deemed it necessary that every antidiabetic which should be released on the market should do a post study for us to ascertain the efficacy and safety of these products. So we did the DECLARE, and the DECLARE is the largest and longest study ever done because we enrolled 17,000 patients over 4.5 years. And 60% of these patients were at the primary prevention stage, and 40% were, I have 10 minutes, 40% were type 2 DM with already established cardiovascular disease. So we look at the primary endpoints, which is composite of cardiovascular death and hospitalization for heart failure. We saw a 17% relative risk reduction. And for the hospitalization for heart failure alone, we saw a 27% relative risk reduction. But for the secondary endpoint, which is the composite of renal events, we saw a 47% relative risk reduction. Now, these are the figures that have shown that indeed Forxiga is not only superior in HbA1c reduction, but also offers cardiorenal protection for the patient. We went on further to do a heart failure study with the primary endpoint, which is the composite of cardiovascular death and worsening of heart failure. We saw a 26% relative risk reduction, with the number needed to treat being 21. Okay. And when you do the subgroup analysis, for the heart failure study, we did both heart failure patients with type 2 diabetes and without type 2. So you could see that heart failure patients without type 2 diabetes, we saw a 27% relative risk reduction compared to placebo. We went on further to do a DAPA CKD study where we also compared CKD patients with or without type 2 diabetes. And we have about 97% of these patients being on the maximum tolerable dose of ACE inhibitors. So for the primary endpoint, which is greater than 50% decline in eGFR of less than 60, end-stage kidney disease, renal or cardiovascular death, we saw a 39% relative risk reduction compared to placebo. And then for CKD patients with or without type 2, specifically CKD patients without type 2 diabetes, we saw a 50% relative risk reduction. So Forxiga doesn't only benefit patients with type 2 diabetes, but heart failure in CKD patients without type 2 diabetes, Forxiga shows some benefit in there. Okay. And this is the secondary endpoint, which is 31% relative risk reduction in all-cause mortality versus placebo, and 29% relative risk reduction in CV death and hospitalization for heart failure. So Forxiga is not only indicated in type 2 diabetes, but for HFrEF and then CKD with or without type 2. And it's taking 10 milligrams daily with or without meals at the patient's convenience. There's no dose titration with Forxiga. Start and maintenance dose is 10 milligrams. And you can initiate Forxiga at eGFR as low as 25. So 25 eGFR and above. Okay. So Dr. York explained the ADA ESDA guidelines where we saw the recommendation for Forxiga or SGLT2s across borders. So for your ASCVD predominant CKD, you can see your SGLT2 here, Forxiga there. You can see for heart failure in CKD, your SGLT2 with proven heart failure in CKD benefits. If there's a compelling need to reduce hypoglycemia because of the mechanism of action of Forxiga is insulin independent. So the chances of your patient developing hypoglycemia is very low, okay, compared to the other medication. If there's a compelling need to promote weight loss, Forxiga is excellent. So for your patients who are obese, they can benefit from Forxiga. Okay, and now SGLT2s have been added to the, I call it the three wise men, the mainstay medications for managing HFrEF. So your ANIs, your beta blockers, your mineralocorticoids, and then now we have our sodium glucose co-transporter receptors. And also it's strongly recommended in our AHA, ACCA guidelines, just like what I mentioned. Okay, and now currently also KDIGO guidelines recommends giving SGLT2s to manage your CKD patients with type 2 diabetes. Okay, so we have our newest baby on the block, which is Zigdio, and it's dapagliflozin plus metformin extended release. And I brought this slide for us to see how the pack looks like. So we have two different SKUs for that. We have the 10 by 1000 and we have the 5 by 1000. So if your patient is on 2 gram daily dose of metformin, they will do 2 tablets of the 5 by 1000 to make up for 10 milligram of Forxiga and then 2 gram of metformin. And mind you, it's extended release. Okay, so you don't have to take it BD. It's 2 tablets daily and it's with food because of the metformin. And if your patient is on 1 gram daily dose of metformin, they just do 1 tablet of the 10 by 1000. And we all know our regular Forxiga 10 milligram daily. Okay. All right. So to summarize the presentation, Forxiga is not only indicated in type 2 diabetes, but in heart failure or HFrEF, and then now CKD with or without type 2. Thank you very much. All right. So I think Dr. York's presentation, he was asked about the price. So I'll say Forxiga is relatively cheaper than EMPA. So it's 550, 10 pesos at wholesale. Okay. I think they mentioned 590 or 5 something. Yeah. So, yes. So thank you very much.
Thank you. Our next presentation is going to be chronic complications of diabetes, prevention, diagnosis, and management. This will be taken by Dr. Chris Ade, who Dr. Ade is an endocrinology diabetologist resident at Kolibu Teaching Hospital and senior physician specialist at the Trust Hospital. He has practiced for 18 years, always had a strong passion for managing persons with chronic medical conditions in general and diabetes mellitus in particular. Loves public speaking and teaching of healthcare professionals, as well as patients and lay people on topical medical issues. He has worked in various medical settings, including a military hospital, Kwesi Government Hospital, private hospital, and teaching hospital, and has a varied wealth of experience. Let's welcome Dr. Ade.
Thank you very much. My topic is quite broad, so I think I'll move. Okay. My topic is a bit broad, so permit me to move a bit fast. Okay, because we are talking about chronic complications, which is both microvascular and macrovascular. This will be the outline. The focus is on prevention, diagnosis, and management. So I wouldn't go much into the pathophysiology. So that will be brief, so that we can have a look at the microvascular complications and then also zoom in on one or two macrovascular complications. So by way of introduction, the chronic complications of diabetes, we know they are both microvascular and macrovascular. And by macrovascular, we are talking about all the cardiovascular diseases, the acute coronary syndromes, the chronic coronary syndromes, and then the peripheral arterial disease. We can also talk about heart failure, but it has both micro and macrovascular components. And then for the microvascular complications, we all know the retinopathy, the nephropathy, and the neuropathy. Now, in addition to the three microvascular complications, we also have the erectile dysfunction, which occurs in about 75% of male patients, and then the diabetic foot disease, which is the commonest cause of non-traumatic amputation. And glucose, poor blood glucose control is a major risk factor for this. Now, you can also see the number of times that stroke and then coronary heart diseases are increased by the presence of glucose. But I must say that when it comes to macrovascular complications, it is not only glucose which is the main risk factor. We have other risk factors in addition to the glucose. We'll come to that shortly. Here again, we must also remember that diabetes does not affect only the eye and then the feet as well as the kidneys. But then also, when it also causes periodontal disease. So don't forget to also let the dentist also have a look at your patients. At least annually, let them see the dentist. It's something that we forget in our practice. And then another important point over here is that we have what we call the transgenerational effect or the epigenetic effect. So when you have patients with diabetes, when they develop gestational diabetes during pregnancy, and you do not deal with this, the offspring born to such mothers are also at risk of developing diabetes, obesity, hypertension, and other non-communicable diseases later on in life. So what you do for your pregnant women with diabetes or GDM is very important, not only for the mothers themselves, but also for the offspring in the future. Now, all these microvascular complications we are talking about, poor blood glucose control is at the heart of all these with the microvascular. And when you have a poor blood glucose control and for a long period of time, then you put your patient at significant risk for these complications. And with regards to type 1, it would occur after about 10, 15 years after diagnosis. But mind you that type 2 diabetes has a very long asymptomatic period. So at the time of diagnosis, you may already have some of these complications. So in assessing your patients with type 2 diabetes, you must be careful to look for the complications right from the beginning. Even though for the type 1 diabetes, you would have to do that subsequently. Now, with regards to the Okay. So for the type 2 diabetes, randomized trials have demonstrated that the microvascular complications really conclusive from poor blood glucose control. But there are other factors to which are at play. Because you may ask yourself, why would somebody develop nephropathy and another person will not, even though they both have diabetes? So genetic factors would also come into play. Okay. Okay. So evidence implicating a causative role for the chronic hyperglycemia in vascular disease is less conclusive. And that is why I said that apart from the glucose, there are other factors which are at play when it comes to macrovascular disease. Okay, so we all know, I think we've seen this most times from the famous UK PDS. So for drop in the HbA1c, you will reduce long-term complications by the various percentages. So you can see that with regards to the lower extremity. Oh, can somebody come and sit here, please? Okay, so for every 1% drop in the HbA1c, you have significant reductions in the various complications, as you can tell from here. 43% for the lower extremity amputation, up to about 12% for the stroke. So you can see that for the microvascular complications, a reduction in the A1C significantly reduces the incidence of these complications. But like I said, for the macrovascular complications, there are other factors in addition to the poor glucose control. So the UK PDS also gave us what we call the legacy effect, which is very, very important because as the word suggests, legacy. So something that you are leaving, for the future. So it was obvious in the study that those who had very good control from the beginning, over the long period of time, still sustain some benefits. So you will notice that with regards to the initial intervention, the percentages drop in the various conditions over here. And post-trial, when they did the monitoring, they still saw a significant benefit. So the key point here is that when you diagnose your patients with type 2 diabetes, you must be aggressive in managing the blood glucose because over the long period of time, you would they would get benefits even after the control has become poor over time. Because in trial conditions, they are quite strict, but later on when they are in the real life, we relax conditions. Now, the total risk factor control, I kept on hammering that macrovascular complications, you also have to deal with the other factors apart from the sugar. And then the steno trial conclusively proved this. So what they did over here was that they took patients who were at high risk with microalbuminuria, and then they paid attention to controlling all the factors. So the blood pressure, the sugar, and then the cholesterol. And then they noticed that for those who are in the intensive therapy, that is the blue, the various complications, there was a lower incidence of the various complications. So that goes to buttress the point that you must not just focus on the blood glucose when you are dealing with the macrovascular complications, but you should look at the other risk factors, blood pressure, cholesterol, and other factors. Now, when we come to the microvascular complications, like I said, the pathophysiology will be brief. So there are both functional and structural abnormalities which occur. But the hallmark of diabetic microangiopathy is thickening of the basement membrane. And these things would eventually lead to leakages, and then you would have seepage of protein and other substances into the extravascular space. And that is what basically happens over here. Now, the there's increased viscosity, disturbed platelet function, and all that. But like I said, we won't go into details regarding this one. And some mechanisms have been proposed. We would also just mention them in passing for those who are really interested in the academic aspect. So you have the advanced glycosylation end products, which is usually non-enzymatic. And then the glycosylation of the proteins lead to problems in future. The other hypothesis, we have the polyol pathway, where the increased glucose leads to increased sorbitol. And then the high sorbitol level causes a lot of the damage that we see. Then the last mechanism is the protein kinase C. So these are the three main mechanisms underlying the complications in the diabetes, microvascular complications. So we come to the neuropathy. Now, diabetic neuropathy usually involves several nerves. So it's not only the sensory. The sensory, you can have the motor, you can have the autonomic. But I'm sure we most of the time focus on the sensory ones because that's the commonest. The distal sensory neuropathy is the commonest. But it can affect cranial nerves, can affect peripheral nerves. Now, it affects over 50% of diabetic patients. In fact, it's the commonest complication. And why we are worried about this is that it leads to ulcers, foot deformities, and then eventually amputations. You can also have erectile dysfunction. You can have cardiovascular and GI complications. We normally forget about the cardiovascular ones, but you can have cardiac autonomic neuropathy, which can lead to sudden cardiac death. Then the types, like I said, you have the sensory, the motor, and then the autonomic. So this is a very simple schema showing the different types. So up there, we have the sensory and then the motor. These are as a result of demyelination of the nerves. And then with the sensory component, you have impaired perception in pain, temperature, vibration, and this can lead to mechanical, thermal, or chemical injury. So we have patients, I saw a patient not too long ago, she had no sense of pain, and therefore put even no sense of temperature sensation. And then she put her foot in hot water. And I mean, it's so bad. She's now being managed at the wound clinic so that we will not lose the limb. So it's important to note that you can have all these components affected. With regards to the autonomic, you would have poor wound healing. When you have the dry skin, can lead to fissures and then infection. And ultimately, all this will lead to a foot ulcer that, if not managed properly, can eventually lead to amputations. Then the risk factors: elevated lipids, blood pressure, smoking, increased weight gain, genetic factors, advanced age. So I keep on hammering the point that don't just focus on the sugar. Even though the sugar is the main culprit in microvascular complications, you must have the total picture, as was demonstrated in the Steno 2 trial. So keep your eyes on the ball and don't let either of the balls fall. So some of the features are pain in the extremities, or you can have numbness, unsteady gait. They may have injuries. You may have a patient with a nail stuck in the foot, and if they don't examine the foot or you don't examine it, they don't even know that it is there because there is loss of protective sensation. So diarrhea, regarding cardiovascular and the GI disturbances, you can have diarrhea, constipation, you can have palpitations, dizzy spells, gustatory hyperhidrosis. So when patients give you complaints, like for instance, the gustatory hyperhidrosis, don't just dismiss them. It could be the earliest sign that you are having a neuropathy. And like I said, neuropathy is sensory, motor, and then autonomic. So keep the other components in mind too. Now, how do you diagnose a DM nephropathy? It's largely clinical, so based on the symptoms. But there again, some patients may not have any symptom at all, and it is your screening that will detect it. So when you examine the patients, when there is absent or reduced reflexes, and then there are some neuropathy scores, like the Michigan Neuropathy Screening Instrument, both the symptom and examination score. There are other scores that can be used to assess the risk of diabetic neuropathy. And then your clinical examination, the monofilament, the vibrometer, the temperature discrimination, all very important. The gold standard, of course, is the neurotessiometry, where you do the perception to volts. So you do the vibration perception threshold, and then you can confirm. But you don't really need that. If for research purposes, you can focus on that. But in practice, you don't really need to wait for the neurothesiometer before you can make a diagnosis. You can always make your diagnosis based on the clinical aspects. But by and large, the electromyography and nerve biopsies should only be done in cases where you are not sure that you are dealing with diabetic neuropathy and that other possibilities can occur. Then you can do those ones. But by and large, it's clinical. So this is how the normal nerve looks like. You know, very nice with a sheath around it. And then this is like something that has been attacked by a dog or a cat. So you see, you've damaged all the surroundings. So what I always use as an example for my patients is that the nerves are the electrical wires with the insulation around them. So when the insulation around the nerve is damaged, as you can see happening over here, then you have all that distorted perception of pain, numbness, tingling, etc., etc. So the symptoms are the neuropathic pain, which can be worsened even by just contact with bed clothes. So sometimes they tell you that when I sleep at night and then the bed sheet touches my feet, I have pain. That should be a sign that you are developing a neuropathy. Then the unpleasant sensations. Then here again, the autonomic neuropathy, which I don't want you to forget. There is impaired vessel regulation, so there can be dryness of the skin. This can lead to fissuring, infection, and all that. So always keep that one too in mind. So by and large, this is what happens. So you have neuropathy or a vascular disease, usually a combination of the two. And then when the patient experiences trauma, it leads to ulceration, there's failure to heal, infection supervenes, and then ultimately you may have amputation. So we want to prevent these complications. So what do? We really have to examine the foot. And there are a lot of things to do in examining the feet, but I'll be brief. So you take off the shoes, then you look at the shape, the foot shape. You look at the dermatology, and then, so these are some of the examples. So you can see calluses at the pressure points over here. You can see that there is a nail stuck in there, and the patient was not aware, and you have to examine to see this. Or the patient has to be told to examine their feet, and then they may pick this one. Now, you can also see that there is loss of the small muscles in there, and this has led to clawing of the toes. So I told you that the neuropathy is not only sensory, so it can also be motor. So you see, because of the loss of the small muscles in there, you have these problems. You can have hallux valgus, you know, the deviation. You can have dysplastic nails. Then you come over here, you can see that this is not how a normal foot looks like, the bottom. So you have a rocker bottom foot. You are having Charcot arthropathy. So there's distraction of the normal architecture, and then the foot becomes flat. You can see that the skin is quite dry. You know, you are setting yourself up for fissuring and then subsequent infection. You can also see that in between the toes here, you have fungal infections. Then the erythema we talked about, you can see some reddening over here. So you really need to assess or inspect the feet of your patients so that you can prevent this ugly complication of neuropathy and subsequent amputations. So you should do the 10-gram monofilaments. I'm sure we all know how to do this. You do that. These are the points that you should pay attention to. This is the 10 points, but you can also do the 4. So instead of doing all the 10, you may do just 4, and that will also be enough. So you use your 10-gram monofilament, apply the pressure until it buckles slightly, and the patient should be able to sense this. If they don't sense it, there's a problem. Then you should also use your tuning fork to check for vibration in the big toe. You can also use what we call the tip term, which is a device for just sensing difference in temperature. If you don't have it, it's not a big deal. You can just use the test tube. So you have one cold water and then one warm water, and they should be able to tell you the difference when you apply. Then you should also do your ankle reflex. But this is not very sensitive in elderly people. So when your patients are quite elderly, you should be very careful about how you interpret this. So the diagnosis, like I said, is largely clinical. And once you have the symptomatology, you should make the diagnosis. And once you have a defect in any of the examination findings, as we have described, you should also make your diagnosis. This is one of the instruments I talked about. They just need to answer the questions, and then you'll be able to tell whether there is a high likelihood of neuropathy. Then the examination, which just relies on what you have already done, then you can also assess. So in screening for patients, for the patients with type 1 diabetes, you should do it after about 5 years. And then for those with the type 2, like I said, they may already have the complication even at the time of diagnosis. So you pay attention to that. Then when you finish with your examination, you can just use this simple risk profile system, and then to determine how frequently you should do the foot examination. So if everything is fine, there's no sensory neuropathy, once a year is fine. If there's sensory neuropathy, every 6 months. If in addition to sensory neuropathy, you have any vascular peripheral disease or any foot deformity, you do it every 3 months. And please, for a patient who has already had an ulcer, don't do it yearly. Every 1 to 3 months, you should examine their feet. The last thing about neuropathy is that you should always keep in mind that there are other differentials. So there are times when we treat our patients for diabetic neuropathy and then there's no improvement. You change the medications from Lyrica to amitriptyline to statin to whatever, there's no improvement. You should think of the possibility of another condition being responsible for their nerve problems. So these differentials should all be borne in mind. Then the treatment goals are quite straightforward. Good glycemic control, because I can't emphasize it enough, that microvascular complications, by and large, poor glucose control. Then you can give them symptomatic treatment, and then this will help to halt the progression. So the symptomatic treatment involves some of these medications, but education is very important to prevent the complications. And then some of the medications that you can use, amitriptyline, carbamazepine, and all that. But like I said, the education is very important. You know, they should keep their feet moisturized, but not in between the toes. They should trim calluses. No diabetic patient should walk barefoot. That is very important. I know people have this feeling that when they walk on stones and all that, they are massaging their feet and improving the blood flow. You should warn your diabetic patients against doing that. So that will be for the neuropathy. And then we'll quickly look at the retinopathy. Like I said, it occurs after about 3 to 5 years in type 1 diabetics. But for the type 2 diabetics, it can occur at the beginning. And the prevalence increases with the duration. And so for the patients at the time of diagnosis, or even 5 years, it can be just 1.25%. But see what happens at 35 years duration, 67%. So it's quite important we really look for this and then halt them. You may not be able to prevent it entirely, but at least you can delay it. So 1 in 3 people living with diabetes will develop a diabetic retinopathy. There are already more than 93 million people living with eye problems. This is just a beautiful picture of the normal eye, as you can see over here. And then when diabetes begins to cause damage, you see things happening over here. We won't go much into the details. One thing I like about diabetes is that it is multidisciplinary team management. So don't be a hero. Get the other people involved. Get the ophthalmologist to see your patients. How many of us remember how to do fundoscopy? I'm sure we have all forgotten. When I was doing my rotation eye clinic, even the ophthalmologists, because now they have the slit lamp microscope, most of them don't even use the ophthalmoscope anymore. So please send your patients to the ophthalmologist at least once a year. Let them have a look at them, because vision loss can have a devastating effect on the patient. You can have psychosocial problems, physical problems, loss of independence, and then work and social integration issues. So vision loss really has a very significant effect on the patient. As for the pathogenesis, like I said, it happens in all the micro. So thickening of the basement membrane, then there is increased permeability. Don't have to have all this headache. Let the ophthalmologists also share in the burden and then let them see. So you don't need to, we used to memorize all these things when we're in medical school. I think now you can keep your head for some other things and then let it be the headache of the ophthalmologist. Even those of us right, still need to know this. So please, if you have exams to write, like I do, pay attention to some of these details. So how do they present? They have flow tests, blurred vision, and then if you don't do anything about these things, then blindness would set in. But please, once symptoms commence, it may be indicative of advanced disease. So screening. I'm always reminding myself of the topic. It is prevention, diagnosis, and management. So we want to prevent the complications. And if you are unable to prevent them, please diagnose them early so that you can manage and then prevent further worsening. The treatment here again, control the blood pressure. Aspirin is not useful. I know there has been debate. Sometimes aspirin is important, aspirin is not important. The consensus is that aspirin is not useful. Then they can do vitrectomy, laser therapy, steroids, antivascular endothelial growth factor, like bevacizumab, and then there are other newer drugs. But like I keep on saying, send them to the ophthalmologist and let them deal with their problems. So screening, which is important to me, at the time of diagnosis for type 1 diabetes, you don't really need to do much in terms of picking these things because it takes time for them to occur. So 5 years after diagnosis, then you start your screening. And then subsequently, every 1 or 2 years, you should screen them. But if it is type 2, as soon as the diagnosis is made, please start the screening. And then subsequently, every 1 or 2 years, you should continue. If it is gestational diabetes, as soon as the diagnosis is made, send them to the ophthalmologist, start the screening, and then if the diabetes resolves after pregnancy, you don't need to do anything. But if it stays, then you treat them like you treat a type 2 diabetic patient, and then every year you should check their eyes. So today, we cannot definitively prevent development of diabetic retinopathy, but prevention of related moderate to severe visual impairment is in our hands. And we all have to work together in order to save the sight and maintain the quality of life in people with diabetes. So that will be for the retinopathy. Let's look at the nephropathy. The nephropathy, I'm very happy. Dr. York, I think, did justice to this. So half of my work is done. They say that if you are standing on the shoulder of giants, you see very far. So I'm happy that I followed my 2 bosses so that some of the things I can skip them. So nephropathy is defined as persistent albuminuria. You remember Dr. York said you should not just focus on the glomerular filtration rate. Albuminuria is the first problem before there's decreased glomerular filtration rate. And then subsequently your blood pressure begins to rise. And this will affect about 1/3 of your patients with diabetes throughout their life. The risk factors here again, the duration of the diabetes, if there's a family history of hypertension, cardiovascular disease, and then a kidney disease, your hyperglycemia, microalbuminuria, male gender, and then cigarette smoking. So this is a natural history. So at the time of diagnosis, your functional changes are already taking place. Then later the structural changes would come in. Then your blood pressure will begin to rise. Microalbuminuria. All this is at the time of the diagnosis. Okay. So you see that by the time you get to frank proteinuria and then your creatinine begins to go up, you are quite advanced. This is the years. You are quite advanced before you get to the end stage. So the good thing about this graph is that we have enough time to intervene and prevent the development of frank nephropathy and then subsequent end-stage kidney disease. So that is why screening is very, very important. And we all know from all that has been going on in the media with the renal dialysis unit and all that, we know that majority of the patients who are on dialysis have diabetes. You can see over here, 50%. If you add hypertension, almost 30%. So between diabetes and hypertension, about 80% of all patients on dialysis, it will be because of these two. And I'm sure you all know that there are very few patients who have only one of these conditions. I call them the unholy trinity. Diabetes, high blood cholesterol. They go together and they cause a lot of havoc. So we need to really pay attention to screening this one. The pathophysiology still runs through the same thickening of the basement membrane and then the formation of the advanced glycosylation end products leading to increased leakiness of the vessels, and then you have all these problems. There are two types. We have the diffuse type and then the nodular form. This is the famous one that we all used to write in medical school, the Wilson lesion. I think we used to love the name. You know, that's for just academic purposes. But this is what happens. So you have scarred tissue. You know, the glomerulus is damaged, and then you have scarred tissue in there. This slide is very, very important to me, so let me take my time. If you don't get anything at all from the nephropathy, what you get here is okay for me. So what you do is that the routine analysis, you do the routine urine analysis. Then, is there protein? If the answer is no, you go and do your urine albumin creatinine ratio that Professor York talked about. If there's no microalbumin, then you rescreen the patient in 1 year. If there is microalbuminuria, you repeat it. You repeat it at least twice within the next 3 to 6 months. Just one microalbuminuria is not enough for you to say the patient has microalbuminuria. Then if you repeat it and then 2 or 3 out of the test, if it's negative, then you go back to rescreening in a year. But if 2 or 3 out of at least 2 out of the 3 tests that you have done is positive, then this is incipient nephropathy, and then you begin the treatment. I think Prof. York talked about the treatment. Then on the other side, if there is proteinuria, you do a quantitative measure, still with the urine albumin creatinine ratio. And if it is in the typical diabetic nephropathy range, which is usually more than 500 micrograms in a day, then your diagnosis is overt nephropathy, and then you begin the treatment. If it is not within the typical diabetic range, you should assess for other possible causes. Okay, so please, if you don't get anything at all, please get this one and help prevent the nephropathy in the diabetic patients. So the clinical features, usually asymptomatic. That is why I keep on stressing on the screening. And for those, you have foamy urine, fluid retention, increased incidence of hypoglycemia. So if your patient begins to get hypoglycemia, you should suspect that they may be getting kidney problems, and then can go all the way to anemia and then uremic features. The classification, you can still use the normal KIDIGO classification. Treatment, you should control the blood sugar, use ACE inhibition. That's why I said that Prof. York talked about some of these things, so I think I'm okay. And then you get the renal physicians involved. Get them involved quite early. Certainly, if the EGFR falls below 30, you should refer them. But even if it is not below 30 and there's proteinuria, you should really get them involved early, so that you can use the SGLT2 inhibitors. The thing about evidence-based medicine, which we are practicing now, is that if there is evidence accumulated through clinical trials, you should let your patient benefit. It will be unfair on the part of the patient for his doctor not to update himself with current evidence and then deny the patient the benefit. So please, even if the EGFR is more than 30, but there are issues with the albuminuria and microalbuminuria, start them on the SGLT2 inhibitors. If you are not comfortable, if you are not familiar, please refer them to the renal physician or any other person who is comfortable to initiate. So that will be for the microvascular complications. Then for the macro, I will just focus on one. I know I have very limited time. I'll just focus on one. The heart attacks and the strokes, I'm sure we are all very conversant. What we don't normally pay attention to is the peripheral arterial disease. So just something small on that one. So these are the risk factors for the cardiovascular disease. Like I kept on saying, there are other factors apart from blood sugar. So I keep on hammering this, so I don't want you to forget. So these are some of the other factors, modifiable and non-modifiable risk factors. So pay attention to them. And then for patients with diabetes, outcomes of macrovascular diseases are usually worse than those who don't have diabetes. And females, we all know that when it comes to vascular diseases, females have a protective factor. But when you have diabetes, you lose that protection. It's just like a woman getting to menopause. We say that once you get to menopause, you are man, woman, you know, you lose that factor. And diabetes also does something similar. So when we say diabetes, we used to, I'm sure Dr. Atiasi will remember that she really loves mentioning this. If you have diabetes, you are just like somebody who has already had a heart attack. And that statement is really true. And this is the evidence. So for somebody who doesn't have diabetes, no prior heart attack, you see what is happening over here. And then if you've had a prior attack, this is it. But for somebody who has diabetes, when you have not even had a heart attack, you are at the same level as somebody who has already had a heart attack. So please, this statement is very, very, very important, that diabetes is a coronary risk equivalent. So pay attention to this. Diabetic patients in terms of managing their blood pressures and their glucose. That is what I want this to say. You still see that if you have diabetes, you are likely to die from a cardiovascular disease. About 40% ischemic heart disease. If you add stroke, that's about 10%. That's like 50%. So ischemic heart disease and stroke, that's more than half. You know, so please, I can't overemphasize the point that don't just focus on the glucose. Just look beyond that. And this is how all these things come into play. You see them always, you see my three friends that I talked about. And then they will bring other people. Obesity, insulin resistance, the genes, and they will all end up in the cardiovascular disease. So you need to keep your eye on the ball. This slide also illustrates the fact that pay attention to the A1C, the blood pressure, and then the cholesterol. Keep an eye on the ABC. Because if you look at this, between the 1988 up to 2010, the people who were at target for A1C, blood pressure, LDL, and those who were on statins, 81.2% of patients did not achieve the composite AB1C. So we need to keep juggling the balls and keep our eyes on all the balls so that we don't drop in. So the peripheral arterial disease, you have these symptoms, intermittent claudication, pain in the buttocks and all that. You should do your complete examination of the lower limb, listen to breathe, do the ABI. The arterial ankle brachial index is very important. We are looking at prevention, so you should be doing that in your patients. Don't just focus on the glucose. A1C, most people would have a target of less than 7%, but Dr. Fisher talked about individualizing the target. So not everybody has to get A1C of 7%. If your patient has advanced kidney disease, getting frequent hypoglycemias, please don't strive for a very tight control. It will lead to mortality. And then they should walk because it improves collateral vessel formation. You can use drugs like pentoxifylline and cilostazol. And then currently aspirin and enoxaparin combination, as well as clopidogrel and enoxaparin combination, can also be used. But the risk of bleeding is increased. So you have to be careful if you are doing that. You need to pay attention to tobacco cessation. I think we are fortunate. Most people don't smoke over here. And then nowadays we have the vascular surgeons. So if the condition is advanced, or is not responding to medical therapy, please send them to the vascular surgeons so that they can also make an input. You still see that the glucose control, blood pressure, cholesterol, individualized diet and lifestyle, it still keeps occurring. So please pay attention. And then the last bit is the lipids. I hear doctors say that, oh, the patient's blood cholesterol is normal. What is normal blood cholesterol? You need to risk stratify your patients and treat them to targets. It's very, very important because you have already seen that diabetes is a coronary heart disease risk equivalent. So you must have targets and you must even be prepared to use non-statin therapy. So this is another important slide I want you to take home if you forget everything about lipids. So the risk stratification, we have low risk, moderate risk, high risk, and then very high risk. So these are the targets for moderate risk, less than 2.6, and then for high risk, less than 1.8, and then for very high, less than 1.4. You can just Google this one and then look at what constitutes the various risk. There's also the score that you can use. But of course, if your patient has already developed a stroke or an MI, you don't need to do any scoring. They're already very high risk. So please pay attention to this. And then from today, we don't want to hear that you are presenting a case to your superior and you say that the patient's blood cholesterol is normal. There is nothing like that. So these are some of the high intensity, moderate intensity, low intensity. I'm sure we are all familiar with this. So this is the last but one slide also, I think. So in trying to prevent, diagnose, and manage all these complications, we want you to, after the diagnosis, improve the glucose control to reduce the symptoms as well as the microvascular risk, and then reduce the macrovascular risk, especially by controlling the lipids and the blood pressure. Very important. Then the comorbidities, you should also deal with them. I'm happy that the psychiatrist is coming after me because depression is also one of the mental health challenges that we deal with in our diabetic patients. So the multidisciplinary team management that I talked about, get a psychiatrist involved, get the psychologist involved, make your work easy. So in conclusion, I will say that remember that diabetes is more than hyperglycemia. Don't be glucocentric. Treat the composite risk factors, especially to reduce the macrovascular complications. Thank you very much.
Have your questions and then we'll answer them at the end of the presentation. The next presentation is by Novo Nordics. Please, can we let them wait? Our psychiatrist has to go back to Kumasi. So we'll let her do her presentation, then we'll do the Novo Nordics. Thank you. From Kenya. Sorry, I understand he's online from Kenya.
Hello? Hello? I hope everybody can hear me. I hope everybody can hear me. Could someone just give me a cue if I can start? I don't know if you're able to hear me. Is the audience able to hear me? Hello? Hello?
Yes, we can hear you.
Okay, thank you. Thank you so much.
Thank you so much.
Allow me to just switch off my screen so that I don't have any lags, so that I can start presenting. So my name is Dr. Brian Ahoa. I'm the medical advisor from Novo Nordisk in Kenya. It's a pleasure being here with you and speaking amongst the giants. Let me begin a story of John Doe. So John Doe is a 23-year-old male. He was diagnosed with type 1 diabetes at the age of 11. And at his diagnosis, his A1C was at 7.3%. He was initiated on NPH insulin before he was switched to vasobolus with the goal of lowering his A1C below 7.7%. And this, of course, now to avoid microvascular complication. However, he had a prior history of nocturnal hypoglycemia since the age of 14, which was constantly associated with seizure activity. Despite having a normal EEG, frequent hypoglycemia episode persisted through 23 years of age, and of course now this was followed with the seizure activity. To address the issue of hypoglycemia, as CGM was ordered to closely monitor the vasobolus rate, and of course it was reduced to prevent further hypoglycemia. But unfortunately, the patient was found dead in bed and disturbed just 20 hours after starting the CGM. The autopsy revealed there were no major anatomical abnormalities, and that was the unfortunate case of John Doe. I want to highlight that this case highlights a very tragic case that serves a reminder of the ongoing challenges in diabetes management and the critical role that medical industry experts have to play in advancing and, of course, our understanding in the treatment of this complex disease. Now, if we go further to this, we see a snapshot of what happened to John. It shows that nighttime episodes of hypoglycemia can be lethal, resulting in death in bed syndrome. So if you look at this, you see that at some point between 5 a.m. and 8 a.m., this is when John Doe was actually diagnosed as dead. But you see that the body was trying to, as much as possible, try to respond to counter-regulatory hormones, trying to bring back him from the hypoglycemic episode, but unfortunately led to his death. What did John Doe tell us? He informed us that there is more beyond A1C. Remember that his A1C was 7.2 and they actually wanted to control it to lower than 7.3. But unfortunately, once we are looking at a patient, we have to look beyond the A1C. We'll come to realize what we mean by that. Secondly, we saw that nocturnal hypoglycemia is a serious concern. And third, that hypoglycemia unawareness can be tragic, and that iatrogenic hypoglycemia is a common occurrence. So if we go further and we try to reduce what we mean looking beyond A1C, is one thing that is often overlooked. That's variability and hypoglycemia. Two very important key metrics that we usually overlook. And by own understanding, this is why I say that the rubber meets the road. What do I mean by this? When you're looking at the burden of nocturnal hypoglycemia, you see that 10% of patients with type 1 diabetes and type 2 diabetes report nocturnal hypoglycemia in a setting of 1 month. And that more than 50% of patients with type 1 and type 2 diabetes experience events at least several times a month. And then the most shocking thing is that half of all severe hypoglycemic events usually occur at night. This is the time that the patient is alone, there's no doctor, it's him and his condition. Let's go further and look into this. When you're looking beyond A1C, there is usually an association between glycemic variability, hypoglycemia, and cardiovascular outcomes, what we usually call the hypertriad. So the more the glycemic variability, the higher chances of you predicting to hypoglycemia, and the more cardiovascular outcomes that particular patients will have when you're looking at all mess in event. What do you mean by glycemic variability? I want to present for you two particular patients. Patient A has 7.8 A1C. Patient B has the same A1C of 7.8. But if you look at the blue marker or the blue line, you see that at one particular point, this patient was in hypoglycemia. And throughout his particular presentation, he was within the timing range. That meaning that is between 11 millimoles or 10 millimoles or around 8.9 millimoles of glucose levels. But the different patient who has the same HbA1c of 7.8, if you can look, then they constantly have areas of hyper and hypoglycemia. So different patients, same HbA1c, but different presentations in terms of glycemic variability. So one is within the range, but the other patient is completely outside the range. So this is what we mean by glycemic variability. So let me continue with that, and then we keep on going further than that. So we notice that when you're increasing your fasting glycemic all-cause mortality. So this was actually seen in a study when you're looking at severe hypoglycemia, major adverse cardiovascular event, and all-cause mortality, that the moment you have high variability depicted in the gray, then your chances of major adverse cardiovascular events increases, and of course now the overall all-cause mortality will also increase. If we go further into this, we notice that this is also mirrored in both type 1 and type 2 diabetes, that the moment you have high day-to-day variability, it means then your nocturnal episodes of hypoglycemia, both in type 1 and type 2 diabetes patients. But the problem is that the fear of hypoglycemia still conflicts in terms of treatment success for both patients and clinicians. So you're saying that in this particular study, we're looking at what are those percentage of patients, that patients were saying that patients were decreasing their insulin dose following hypoglycemic event, and that when you're looking at the other angle of the HCP will be more comfortable to aggressively manage the patient if there were no concerns of hypoglycemia. So this takes us to another point, saying that it is the consequences of hypoglycemia not only affect the patient and the HCP, but when you're looking at it, there's a considerable burden to both the patients and the society. This can lead to increase in direct costs and, of course, other indirect costs. But there is a solution. In Novo Nordisk, we prioritize what patient safety by looking at how can we develop solutions that take into account the needs of both the patient and the doctors, not only focusing on the patient centricity, but looking at the whole picture of the patient, the doctor, and the society at large. So we have already established this, so allow me to skip this and go to what we wanted to do when you're looking at solving the problem of hypoglycemia, because we already know this is a major concern. Number one, we wanted an insulin that can really, in terms of efficacy, give you good glycemic control. Secondly, we wanted simplicity. We know that if you tell a patient that you need to inject yourself 3 times in a day, 4 times in a day, that becomes more of an issue. So can we make a particular product that has glycemic control? It is simple to the patient and the prescribing doctor. It is predictable and at the same time has lower risk of hypoglycemia. Then for you to make that, then ideally you have to look at the PK/PD profile. You want an insulin that has a flat time action profile. Why? Because if you have an insulin that gives you very high variability, then it means that you'll have episodes of hyperglycemia, hypoglycemias that are not predictable. But Secondly, we want an insulin that has low variability, as already explained, and that the half-life is more than 24 hours. That means that simplicity now comes in terms of the injection, and of course now the potency is there as well. Then there was born now degludec, which is commonly known as Tresiba, was born. What we looked at is when you're comparing degludec and glargine, which we're all familiar with, when you're looking at the half-life in terms of hours, you're seeing that with Tresiba, which is degludec, you're seeing that the half-life is almost double that. Is actually looking at this, the other aspect of it that we call the flat time action profile in type 1 diabetes, and of course now in type 2 diabetes, you see that there's lack of glycemic variability. This means that the insulin is predictable, number one. Number two, you are not very worried as a patient and as a clinician that this patient might actually tip into hypoglycemia at night when I'm not aware of what is happening. So you're seeing that everything in terms of the serum concentration and everything is actually plateauing and becoming steady in both type 1 and type 2 diabetes, but we'll look more into that. So the other thing that I probably missed out pointing out in the story of John Doe is that he had administered with himself, because of the high glycemic variability, the areas of hyperglycemia, he had administered bolus insulin. But we all know that the problem with bolus insulin is stacking. The moment you inject yourself more than short intervals of bolus insulin, there's that probability of having stacking. So with Tresiba, you're actually able to reach steady states without stacking. You're saying that by the time, if you want in your circulation to have 10 units of insulin, by around day 3 and day 4, you are at steady state. And the beauty of this is that you are at steady state. Yes.
Please, you have 5 minutes.
Okay, you have steady state, but without stacking. So this is the importance of Tresiba. So if you're looking at within the glycemic variability, when you're comparing between degludec and glargine, you see that with Tresiba, you have a flat time action profile, meaning that if I'm giving this insulin within the day, I'm not worried about glycemia or hypoglycemia or hyperglycemia as compared to glargine. You see with glargine between 0 to 6 hours, the area under the graph in terms of the insulin infusion rate is high, and then at some point it goes low, and then at some point it goes high. But as compared to degludec, it's flat. That means that insulin is predictable, number one, and you're able to avoid issues about hypoglycemia. The same is mirrored here when you're looking at day-to-day variability between glargine and degludec. You see with Tresiba here in the blue, you see it's almost a flat line. But with glargine, unfortunately, this is all variable. So it means glargine has high variability as opposed to degludec, which is Tresiba, which has no variability or low variability at all. But then you ask yourself then, what really is in terms of efficacy of that particular product? And when you're looking at major adverse cardiovascular events, here, important thing, which was our particular discussion for the particular day, is what does it do in terms of hypoglycemia? You see, in severe hypoglycemia, the rate ratio is significantly reduced in terms of the number of episodes that a person will be having when they are in degludec as compared to glargine. And the other thing, the elephant in the room here being nocturnal severe hypoglycemia, is reduced when a patient is when your patient is using Tresiba. So this means that there's a 40% lower rate of severe hypoglycemia and a 53% lower rate of nocturnal hypoglycemia when a patient is using Tresiba as compared to glargine. So again, the other thing is when you're looking at the other side in terms of titration, it's very simple because of the flat stable action profile. It means it's very easy for that particular patient to monitor the insulin of 2 SMG compared to 4 or 6 per day. And then, of course, now you can adjust your dose once a week. This is what we usually mean by when you're talking about simplicity of degludec. And of course, now it's flexible. If you miss your dose, you just have to ensure that it's within 8 hours. So you can give it at 40 hours in between. And you see all the way, if you miss your dose in the morning, you can give it in the evening. And the same applies all over the place. So yeah. Thank you so much. And all this is thanks to John Doe, just making us to understand what really happens in severe hypoglycemia, and may he rest in peace. Thank you so much.
Our next presentation is mental health challenges in diabetes. This will be presented by Dr. Ruth Owusu Entry. Dr. Ruth Owusu Entry is a senior specialist, head of psychiatry department, Konfolo Anochi Teaching Hospital, lecturer at the School of Medicine and Dentistry, KUNST, and the medical director at Recovery Pathways. Thank you.
Very good evening to us all. I am excited to be here. The thing that I'm happy to realize is that I think there are more psychiatrists than endocrinologists we have here. So at least there is one group, one subspecialty that psychiatrists beat. We just finished our AGSM. At least our room was full. You have half full. So I am encouraged that we are getting more psychiatrists. But it's a good thing that this is actually your 5th AGSM. Ours was the 2nd, even with our numbers. So I really applaud you. You have, there are others online. Great. Well, so it's good you thought about mental health implications in diabetes. Very, very important, and I'm glad that I have this opportunity for us to have this conversation. So, diabetes and mental health. I showed this picture for us to understand how there is a bi-directional effect. People with mental illnesses seem to be more prone to suffering from diabetes. And then people with diabetes also have an increased risk from suffering from various mental disorders, especially depression. There's a whole cascade of the interplay between diabetes and major depressive disorders. But there are other psychiatric conditions. We have personality disorders. We have stress, trauma, abuse. We have generalized anxiety disorder. There is the eating disorders. We have the sleep-wake disorders. That all interplay with people who have diabetes. One causes the other. And as I go on, I will go into a little bit of details about the specific relationships. So in terms of mental illness being a risk factor for diabetes, there's been a lot of research that has proven that psychotropics, especially the second generation antipsychotics, predispose people to suffering from diabetes. Also, people by virtue of their mental illness are likely to not adhere to their medication. They are likely to have poor self-care, which may lead them to suffer from diabetes. There is a major depressive disorder that increases the risk of diabetes type 2, by as high as 60%. Then diabetes can also predispose to mental illness. There's been several studies that prove that depressive symptoms are present in about 30% of people with diabetes. These are just the symptoms. But those who have clinically diagnosed depression are about 10% out of people with diabetes, and they are a double when you compare them to the general population. Now, this comorbidity of depression in diabetes tend to worsen clinical outcomes, especially in type 2 diabetes. And this is because people who are depressed are likely to indulge in any level of physical activities, or they may not adhere to their medications at all. I would about mental disorders that are present in people with diabetes. The first one is what we call the diabetes distress. And now, there is some form of despondency and emotional turmoil that specifically are related to caring for diabetes. That the fact that there is a need to monitor your sugar levels, there's the need to get constant treatment, the fear, preoccupation with complications, and then effect of the disease on relationships lead to people suffering from what we call the diabetes distress. And when patients suffer from this diabetes distress, there's usually poor diabetic outcomes. Other psychiatric disorders are, I've talked about depression. We can have other mood disorders like dysthymia. If you don't specifically ask people about dysthymia, you may miss it because they would present with more lower grade depressive symptoms lasting over a longer period of time. For you to make a diagnosis of depression, you will need low mood, easy fatigability, and anhedonia. Anhedonia is a loss of interest in previously pleasurable activities. And if these symptoms persist for about 2 weeks or more, then you can make a diagnosis of clinical depression. But when it comes to dysthymia, it may not impair the individual's normal functioning. It's just that they accept that their mood has reduced to some extent. Their extent of emotional, their ability to go about their normal duties, their enthusiasm with the general functioning or the general day-to-day activities tend to reduce. And it is usually mild, and so they can go about their normal duties, but they persist for more than 2 years. When it is real depression or clinical depression, it is somehow self-limiting, so it will not last for 2 years consistently. Usually by 8 months maximum, even without any medication, depression would spontaneously resolve. Just that it won't occur again in a severer form. And then we have the generalized anxiety disorders or the anxiety disorders in several forms. People with diabetes are preoccupied with hypoglycemic crisis or complications, especially the younger ones. And so when they come to the clinic, it is important you ask 1 or 2 questions to ask whether they are anxious about anything, whether they are having disturbed sleep, whether they are thinking a lot, whether several thoughts are going through their mind. And that question may be what will lead you to discover an anxiety disorder happening. Feeding and eating disorders have also been found to be prevalent in people suffering from diabetes and schizophrenia and other psychotic disorders. You may wonder why schizophrenia. Schizophrenia would present with psychotic symptoms, so hallucinations and delusions. If the depression is severe, it can lead to the patient experiencing psychotic symptoms where you get severe depression with psychotic symptoms. So ask about specific psychotic symptoms. Are you hearing voices? Do you think that you will not make it in with this disorder? Do you feel that life is no longer meaningful because of this condition? These are all delusions that an individual may be experiencing. Then another relationship between diabetes and then the psychiatry or mental illness I've already mentioned is the fact that the psychoactive medications or psychotropics themselves predispose to diabetes, especially the atypical one. So if an individual has a diagnosis of depression or has a diagnosis of any form of mental illness, you must by all means avoid it if they have a comorbid diabetes. Lifestyle factors also contribute. Comorbid mental illness often worsen diabetes control and causes earlier and more serious complications. How would you manage mental disorders or mental issues in people suffering from DM? The first one is to screen. The first step is to screen. If we would routinely include mental health screening in our daily care, I know what we do as physicians is already overwhelming, but if we want the best for our patients, we would have to go all the way. And there are very simple self-report skills. WHO5, for instance, has just 5 questions, and they could be in the consulting rooms like we have our lab request forms so that you can quickly ask those 5 questions to see the mental wellness of the person. But especially when the patient who has diabetes is considered as vulnerable, and we are talking about people who have a previous diagnosis of any form of mental illness, especially diabetes, we would have to monitor deliberately that they do not relapse. Some of the specific screening tools that can be used, and they are all online. If you want some specific diabetic-related mental illnesses, the screening tools to use are problem areas in diabetes scale. We have the diabetes distress scale. If you want to assess the individual's quality of life, the WHO-5 is very good. If you want to screen the person or the patient for depression or anxiety, we have the hospital anxiety and depression scale, patient health questionnaire, then the popular Beck's depression inventory. These are all online, very simple questions, maximum 10 questions, and you are done screening the individual. Once you have done the screening, you would want to monitor the patients through some laboratory investigations also. Patients who take psychiatric medications in our clinics should specifically go through all these batches of laboratory investigations to make sure that they do not get other diabetes-related complications. Checking of their weight or the BMI, it's important you always get the baseline, but it should be done monthly, 2 monthly, 3 monthly, at least 3 to 6 monthly. You should check the individual's BMI. And then the waist circumference, you can do it at baseline and repeat it every 3 months. At worst, annually should be good. If your patient who is a diabetic is also on any psychotropic, your blood pressure must be done at least every 3 months. And I would even say that it should be done every day. Then the fasting plasma glucose should be done at least 3 monthly for the patient. You get your baseline and you repeat it 3 monthly. The lipid profile can be done 3 monthly. And then personal history of alcohol, tobacco, and recreational drug use, especially the younger patient. We should not think that they are innocent. In fact, there are a lot of young people now using all sorts of substances, and they use it as a way of coping with their stresses. And so if they are overly worried about their diabetic or their sugar control, instead of talking to their healthcare provider, they would want to smoke their worries away or drink their worries away. And the females are now leading in substances of abuse. So don't use the person's face and say that, when I look at your face, I don't think you smoke or I don't think you drink. It should be a routine question that we ask. And of course, if there is a family history of diabetes in your patient, it's advisable that you encourage the rest of the family to come for screening. Someone said that there are young people who accompany their parents to the diabetic clinic or to the hypertensive clinic, and the year at which their parents were diagnosed, they are actually at that year, but they have never checked their own sugar level, they have never checked their own sugar level. So we should encourage family members, especially accompany family members, to screen themselves. What are the treatment options if someone has any form of mental health issues in addition to diabetes? Cognitive behavioral therapy is usually offered by clinical psychologists, but there are some very simple ways we can do it even in our consult room, and I'll show a slide on that. There are other types of psychotherapy, just a psychosocial support, asking the person, how are you doing? Where is your sugar, your lipid profile? But going beyond those simple questions and asking, how are you doing? Sometimes the answers are generic, oh, I am fine. But stressing on how is your sleep, how is your mood, how is your emotional state may help in diagnosing an emerging mental health disorder. Antidepressant medications are available, very effective when the person is going through depression. The SSRIs, especially fluoxetine, sertraline, citalopram are very safe for depression in diabetes. So in cognitive behavioral therapy, especially for people who have fear of suffering from hypoglycemia, you would have to first of all determine their actual sugar level plus their perceived frequency and severity of the hypoglycemic episodes. And then ask simple questions about their concerns in developing the hypoglycemic episodes during the day and during the night. Then normalize the fear response, empathize with them, and ask for their permission to look at the possibility of reducing the fear by means of improving their diabetes control. Ask the person how fear and anxiety has been successful in managing their circumstance. You ask them, so whenever you feel afraid, does it automatically manage your sugar control? And it's a big no. And that is one of the ways to challenge their thoughts, to move from being afraid to face their fears and rather take positive actions to control their sugar. More recommendations that individuals with diabetes should be regularly screened for diabetes-related psychological distress. And this is diabetes distress, psychological insulin resistance, fear of hypoglycemia, and then for psychiatric disorders like depression and anxiety. Plans for self-harm should be asked about regularly as well. Suicide is one of the complications for mental disorders. And so if we are asking people, some have said that when you ask people about suicide, you are the one putting the thoughts of suicide into their head. It's a big no. Because suicide or taking one's life is actually a very difficult thing. When people start contemplating suicide, they feel anxious about it. They wish they can talk to somebody about it. So that simple question, that one question that you will ask, have you ever thought of harming yourself? Have you ever thought that life is not worth living? Have you ever thought that it's enough, you wish you were dead? Maybe that life-saving question, maybe that lifesaver. And so let us routinely ask about self-harm or suicide in our patient. Another recommendation is that collaborative care by interprofessional teams should be provided for individuals with diabetes and especially for those with comorbid psychiatric disorders. When we do that, we improve their existing depressive symptoms or mental health symptoms, we improve their adherence to medications, and then we improve their glycemic control. I'm not sure every diabetic clinic or endocrine clinic can have a resident psychiatrist, but at least if they can visit once a month or every quarterly, it should be a good starting point. Psychological interventions should be integrated into diabetes care and the plan. And some of these things include motivational intervention, stress management strategies, and these are not rocket science. Some of the ways you can tell people to manage their stress, make sure they are eating well, make sure they are resting well, make sure that they are adhering to their medications and all that. Very simple strategies like that. Coping skills training and family therapy. Sometimes we need to invite the family members and sit them down. What are your challenges? What are the difficulties you are facing? Are there challenges with getting treatment for this person, coming for review and all that, so that it can be addressed? Recommendation 4 is that antidepressant medication should be used to treat acute depression in people with diabetes and for maintenance treatment to prevent recurrence of depression. And most of the time, when somebody has suffered a second or a third depressive episode, then treatment at the third episode is for life. And so you encourage the person that as they take their medications for the diabetes, they also adhere to their antidepressants. Cognitive behavioral therapy, like I said, can be used to treat depression either alone, depending on the severity, or it can be done in addition, in combination with antidepressants. Children and adolescents are not left out. Those with diabetes should be screened at diagnosis for major depressive disorder. And for this particular age group, the children and adolescents, their screening for mental health issues should be more regular. These are children who have to deal with a long-standing condition. They have to be perpetually on medication. They are in school on special diet, special arrangement for them. The fact that we help them that they don't feel different or feel abnormal from other children and adolescents is very important. And you know that age, adolescent age, is where people want a sense of belonging. They want to belong. They want to be part of the flock. So if you keep exempting them from a couple of things, that alone can be a trigger for a lot of psychosocial difficulties and mental distress. And so a mental health professional is advised to provide intervention for these young people whenever required. And the sixth recommendation is that adolescents with type 1 diabetes should also be screened using very non-judgmental questions about their weight, their body image concerns, dieting, binge eating, insulin omission for weight loss and all that. If you are asking these questions, you are not asking it as form of judgmental or from a judgmental point of view. But if you ask it from a caring point of view, I'm concerned about how you are doing. I'm concerned about your sugar control. How do you feel about your weight? Is it okay? Do you feel shy sometimes? Are you deliberately avoiding your insulin because you want to lose weight? Or instead of eating, or you are binge eating out of the depression you are going through? These are very specific questions we can ask young people. In ending, I will leave us with some key messages. That the experience of living with diabetes is often associated with concerns specific to the illness and can cause conditions such as diabetes distress, psychological insulin resistance, and the persistent fear of hypoglycemic episodes. People living with diabetes are further at risk of mental disorders like depression, anxiety disorder, etc. And because of this, routine mental health assessment is necessary for protection and management. Compared to those with diabetes only, individuals with diabetes and mental health concerns have decreased participation in diabetes self-care. They have a decreased quality of life, increased functional impairment, increased risk of complications associated with diabetes, and then increased healthcare costs, and special attention should be taken into consideration in their care. Interventions like cognitive behavioral therapy, stress management, coping skills training, family therapy should be incorporated in our routine care of patients with diabetes. Effective medications are available, and I have mentioned some of them. The first generation antipsychotics, if the person is suffering from psychosis, or the SSRIs for depression, are very effective. And healthcare providers should also constantly educate their patients that it is important to acknowledge their emotional turmoil and talk to a healthcare provider about it. I'll conclude on these last two slides that living with diabetes can be burdensome and anxiety-provoking, with constant care demands taking a psychological toll. As a result, many people experience distress, they experience decreased mood, and disabling levels of anxiety. Diabetes is often associated with significant emotional burden, distress over self-care regimen, and stress in relationships with family and friends, as well as with the healthcare provider. Mental disorders can affect one's ability to cope and care for diabetes. It is just as important to look after your mental health as it is your physical health. Thank you very much.
Thank you. Although we said the questions will be at the end, Dr. Owusu-Antwi has to leave for Kumasi. So if there are a couple of questions you want answered, she can quickly answer them before she leaves for the airport. Thank you.
Anybody has a question for Dr. Owusu-Antwi before she leaves?
Thank you very much. Doc, I'm very interested in this concept of psychological insulin resistance. I'm hearing it for the first time. Thank you.
Should we take 3 questions and then you answer them maybe? Any more questions here? maybe I'll ask this screening. How are we able to screen them as often as you say we should? Maybe every 3 months, integrating the care in the clinic. How best can we do that? Any other questions? A third question, and then we can.
So depression is quite common among diabetes patients. So which of the screening tools would you recommend as handy, for routine screening? I know there are many of them, but which one do you think will be should be used?
Okay, thank you very much. I would answer from Prof. York's question. So I think I showed a slide on the various screening tools. The BEX depression inventory is very user-friendly. In fact, it can be self-administered. So you can give it to your client to go home, answer, and bring it back. And then based on the scores, you would be able to place this person. And then there was another question on how often we do the screening. It can be difficult. I mean, the queue waiting for you, and you are spending time asking other questions aside, questions related to the diabetes. But you may not have to use it all the time, but a simple, there is how are you and there is how are you. So that simple how are you with a meaning that you want to find out for real, how are you doing? Are you sleeping well? How are you feeling? Are there difficulties with sleep? Are you feeling down most of the time? Probably just about 3 questions can routinely be asked. And depending on the questions we get, then we can schedule this person for a full screening. And then the psychological insulin resistant. Just like we have psychological blindness, psychological paralysis, we can get psychological insulin resistance. And these are people that you will screen and everything seems normal, but they claim that they are getting some symptoms related to poor insulin control. And usually when you have done every lab, it proves that they are fine, but they will present with symptoms indicating that they may have challenges with their insulin control. And these people usually have underlying challenges that they are struggling to talk to anybody about. Just like we will get people with psychological blindness, they will go and visit the ophthalmologist, everything is fine, or paralysis, they've done CT scan, MRI of the back, everything is intact, but they claim they can't walk. And for most of such people, there are deep-seated, some subconscious challenges that they are struggling to address. And so probably the clinic will not be an appropriate place. You may have to refer such people to the clinical psychologist to further explore what exactly the issues are.
If there are any online questions, CS, over. All right. Okay, all right. I think we can let her go. Thank you.
Okay, thank you so much. Safe flight. Our next presentation is by Novartis.
Okay, so this will be our last presentation. I'm doing the presentation on behalf of Novartis. Okay, so this is a slide, a disclaimer slide. So the views and opinions that I'm expressing are not necessarily that of Novartis. We use this outline. We are looking at diabetes and dyslipidemia. All right. When we talk about this lipidemia, what comes to mind usually would be cardiovascular disorders. And we know that cardiovascular disorders are a leading cause of mortality if compared to other non-communicable diseases. 17.9 million of them, and it's expected to rise to about 24 million by the year 2030. In 60 seconds, about 34 people with atherosclerosis worldwide would have died. So as we are sitting here, quite a number of people would have died either from myocardial infarction or from a stroke. And in the past, or recent advances has kind of reduced the cardiovascular mortality. But recently we've noticed that that reduction has plateaued. And so it's very urgent that we do things that would reduce cardiovascular mortality, particularly among patients with diabetes, because they are at a high risk of developing cardiovascular disease. Even those with pre-diabetes have a high risk of developing cardiovascular disease. They also are at a high risk of all-cause mortality. And when you look at it specifically, you realize that cardiovascular disease accounts for a very large proportion of this excess mortality. And we've heard about the risk factors. Dr. Adai talked about cardiovascular risk factors, modifiable and the non-modifiable ones. And from the modifiable point of view, we have behavioral ones, metabolic, and others. For the purposes of this presentation, I think we'll be looking more at the metabolic, specifically the cholesterol abnormalities. And elevated LDL cholesterol is a major risk factor for the development of atherosclerotic cardiovascular disease. And we are quite familiar with how it does that. Once we are exposed to high levels of LDL, there's progression to the formation of atherosclerotic plaque. And once this plaque ruptures, it leads to either myocardial infarction or ischemic stroke, which you are quite familiar with. This lipidemia in diabetes, the range is quite wide, from 34% to as high as 94%. The patterns of this lipidemia, we know there's elevated LDL cholesterol, but it's quite common also to see patients with diabetes who have elevated triglycerides as well as low HDL cholesterol. Their LDL particles tend to be smaller and dense, and we also know of the lipoprotein A, which is also quite atherogenic. So you come across all these patterns in our patients at the clinic. The longer we are exposed to high levels of LDL cholesterol, it increases the risk of developing these cardiovascular diseases at an earlier age. So this slide is showing that if you're exposed to high levels of LDL cholesterol at as high as 5.1, you will develop your cardiovascular disease at a younger age, less than 40 years. Whereas somebody who is exposed to a level of, say, 2 is most likely to develop his myocardial infarction at 100 years. By that time, something else would have killed the patient. And so long-term exposure to persistently elevated LDL cholesterol is a major risk factor. And LDL cholesterol has been found to be one of the risk factors that is readily modifiable when it comes to cardiovascular diseases. So on the other hand, if we are able to lower LDL cholesterol, then we can modify the course of the cardiovascular diseases. So if you lower it to a much lower level, your risk drops. Your risk of developing, for this case, is myocardial infarction, will drop. So from 3.2 to 2.0, you get additional benefit. If you start the lowering at an earlier age, also you get additional benefits. So somebody starting at the age of 50 years, the lighter yellow, that's the benefit. But if you start at a much earlier age, there's additional benefits. And so when it comes to LDL cholesterol, the earlier you lower it, the better. And then the lower the level also, it's better for our patients. For every 1 millimole reduction in cholesterol, there's a 20% reduction in the risk of developing major cardiovascular events. And we know that statins are the main or the first line when it comes to lowering LDL cholesterol. And it does that by reducing the synthesis of cholesterol. So they are in the hepatocytes, the intracellular cholesterol level drops. And when that happens, it stimulates the upregulation of LDL receptors to be able to mop up more cholesterol from the bloodstream, so that eventually you have a reduction in the LDL cholesterol in the circulation. So that is something that we are quite familiar with. So when it comes to lowering the cholesterol, the approach that we usually would take would be, we have to identify what dyslipidemia the patient has. And once you identify, we know there are other causes, so secondary causes. We need to make sure that that patient doesn't have a secondary cause for the dyslipidemia. Then we assess their cardiovascular risk. After assessing the risk, you're able to select what statin therapy, the intensity that patient requires, and then their corresponding goals. Then we start the treatment, lifestyle, statin therapy. And whilst we are treating, we need to be monitoring the patient for toxicity, side effects, and adherence to therapy. So that's the usual approach we take. For patients with diabetes, in terms of assessing for the risk, we can categorize them into two groups. Like any other patient, we have primary prevention, secondary prevention. So for those under primary prevention, that they haven't had any cardiovascular event between the ages of 20 to 39 years, if they have an additional cardiovascular risk factor, then we can initiate statin therapy. For those who are between 40 to 45 years to 75 years, these are the categories and their corresponding statin therapies that is recommended. If they don't have any cardiovascular disease at all, as Dr. Adai said, is their cardiovascular risk equivalent. So you still need to put them on some moderate intensity statins. Where they have one or more risk factors, then we go to high. Occasionally, you may want to risk stratify your patient using the various scores that we have, only to determine whether you should put them on moderate or high intensity. But the agreement is that once they have the diabetes, they need to be on some form of statin therapy. Older individuals, moderate intensity is recommended. And for all ages, the moment you get a cardiovascular disease, you need high intensity statin therapy. And we know the various categories. I think Dr. Adai showed us the high, the moderate, the low, and the medications that do that. For the diabetes patients, we usually wouldn't recommend low intensity statin therapy for them. And in addition, we go with their diet, their physical activity, make sure they lose weight if they need to. Targeting the LDL targets usually for primary prevention. If they've not had any event, we are aiming at more than 50%, and then the LDL level should be less than 1.8. I think that was seen earlier. And for secondary prevention, more than 50% reduction LDL, and the level should be less than 1.4 millimoles. We also need to make sure that the glycemic control is good, blood pressure is good, and their triglycerides and HDL levels are also good. But there are several barriers when it comes to managing patients or patients who are on statins. We know that is the main one. Most people are, as much as 94% of patients are on statin therapy. But there are certain barriers that prevents us from achieving the targets that we've just looked at. And some of the potential reasons may be from the healthcare providers' point or maybe from the patient's point of view. But one that is quite common is statin discontinuation. You will start all right, but the patient will not continue taking the medication. Some of the reasons have been outlined in this study, but the most common one is because of side effects. So in this study, 55% of patients discontinued statin therapy because of side effects. And the moment you discontinue, the risk goes back up. Risk of cardiovascular disease goes back up. So if we have a patient, or if we have patients who are on statin therapy and they are not able to achieve or maintain their LDL cholesterol goals, then it means that it's time for us to do something, to add on other therapies to be able to achieve the goal so that we reduce their risk of developing cardiovascular events. So some of the other therapies that are available, we have ezetimibe. We know it's a medication that would inhibit the absorption of cholesterol from the GI system and is able to lower LDL cholesterol between 18 to 22%. We also have medications that work on or modulate PCSK9. So PCSK9 is proprotein convertase subtilisin kexin type 9. Very long name, but PCSK9. So it usually does is that it tags our LDL receptors on the cell surface, and once it tags it, it means that receptor is tagged for destruction, more or less. So the moment the LDL binds to the receptor, it's taken up into the cell, and the cell, once it goes inside, the LDL receptor is destroyed or degraded. That means we are going to reduce the available LDL receptors on the surface of the cell, and therefore uptake of LDL would reduce and the levels of LDL in the blood or in the system would be high. So there are ways of modulating this. One of it is using antibodies to the PCSK9 that would prevent it from tagging the receptors for destruction. Another way is for us to inhibit the actual synthesis of PCSK9. So rather than doing the antibodies that we see up here, we can also inhibit the actual synthesis. And that can be done by the inclisiran, which is a small interfering RNA molecule or agent that inhibits the synthesis of PCSK9. These are other new emerging trends, but I think we'll skip that for because of time. This looks at how inclisiran does inhibit the synthesis of PCSK9. So it's able to enter the cell. It will pair up with the RNA that is going to be used to produce the protein PCSK9. And the moment it pairs up with it, it causes degradation, cleavage and degradation of the mRNA, and therefore there will be no synthesis of the PCSK9. And once there's no PCSK9, the receptors are free to be recirculated onto the surface. There are several studies that have shown the efficacy of inclisiran. And so here there are 3 of them that compares the inclisiran with placebo on top of maximally tolerated statin. And we realized that from these 3 studies in 3 different groups of people, those who have cardiovascular disease, those who have cardiovascular disease equivalent, and familial hypercholesterolemia, there was a reduction range between 47 to 52% of in LDH, in LDL after during the study. They also realized that there was a significant absolute reduction in LDL cholesterol in these same studies between 1.3 to 1.8 millimoles after assessing the efficacy of inclisiran. There's also a percentage of people who were able to achieve their LDL goal. Up to about 74% of patients were able to achieve their LDL goal using the inclisiran. And doesn't only reduce the PCSK9, it reduces total cholesterol, lipoprotein, small a that we mentioned, and also increases HDL levels. When it comes to safety, okay, so this slide is looking at the fact that the inclisiran effect is quite sustained over a period of 18 months. If you compare placebo and then the inclisiran, the reduction percentage change is quite sustained. When it comes to safety, it's quite safe. It was quite comparable with the placebo. The main side effects being is injection site reactions in some of the patients, and these were found not to be severe and they were not persistent. Okay, so usually given as an administration, day one, inclisiran 300 milligrams, repeat in 3 months, is given as a subcut injection, and then thereafter 2 injections a year, 6 months apart. And as we said, we need to look out for the skin reactions in these patients. There's no need for dose reduction in those who have renal impairment. So when it comes to their role in the therapy, it's recommended that they can be added on in primary prevention for those who are at high risk or there are multiple risk factors and they are on the maximum tolerated statin, and yet still their LDL cholesterol is more than the target range, which is 1.8. For secondary prevention, the same, they are not able to achieve their target of less than 1.4 despite being on maximum tolerated statins. And you can add on the inclisiran in these people. Going forward, we still, as we are managing our patients, we need to monitor that what we are doing is effective. And so each time we see a patient who has been newly diagnosed with diabetes, we need to do the profile. When we start them on their treatment, we need to be monitoring their lipid profile at least 4 to 12 weeks to make sure that they are adhering to the treatment. We shouldn't forget that hypertriglyceridemia is quite common in our patients. Most of the time it's not so high, and so you still will target LDL cholesterol first, and once we've reached the target of LDL cholesterol, if their triglyceride levels are still high, then the recommendation is that we could add on the icosapent ethyl medications, which have been shown to reduce cardiovascular risk. In the future, this is a proposed personalized therapy that people are looking at, that instead of doing one medication and then if they don't reach the target, a second medication, we are thinking of looking at how much you expect to reduce a patient's LDL cholesterol level. And so if you think 50% is all that you need, then maybe you just need a statin. If you see that if you think the patient needs maybe up to about 80% reduction, then right from the word go, we are going to give them 3 medications right from the beginning rather than doing one before the other. And if they need more than 80% reduction, then they are going to be doing either 3 medications or in this case 4 medications, and these 2 both would require the addition of a PCSK9 modulator to be able to achieve that aim. So in summary, we've talked about how cardiovascular diseases are a leading cause of cardiovascular disease and mortality. The fact that LDL cholesterol is the most modifiable risk factor for that, and lowering it would improve cardiovascular outcomes. But a lot of our patients who are on statins are not able to achieve their targets, and therefore such patients would require adjunctive therapy. And we've gone through one such therapy, which is inclisiran, which is able to effectively lower the LDL cholesterol with minimal side effects, and the administration is also quite easy. In terms of the cost, I think I'll leave that for the drug reps to talk to us about it. But I'll leave you with this. When we are treating our patients with dyslipidemia, lower is better. The earlier is also much better. Starting earlier is better. And keeping them on the medication longer is definitely better than stopping them when they think the levels are normal. Thank you very much.
Thank you. It's time for questions.
thank you very much for a very excellent presentation. I am going to be a bit controversial here. And my name is Dr. Mfojo. I'm a psychiatrist. And I have worked for Pfizer Pharmaceuticals of a fairly senior level. And so when I had my cholesterol issues, I actually used to have Lipitor for free. Now, one of the things I want to say is that we are taught medicine, we are taught is almost pathological medicine in the sense that we are taught how to treat illness, but largely not to prevent it. I don't know whether anyone has seen the clip by Professor Kosa, Bedria Kosa, about the grain oils as compared to the tree oils, which is coconut, cocoa butter, palm oil, as compared to the canolas and the sunflowers, and their impact on cholesterol. I'm my own candidate in that respect. And since I started focusing on the tree oils, my cholesterol issues have disappeared. So I think that as much as we would like to do the statins, and of course I'm sure you all know about some of the more recent arguments pro-statin, anti-statin, etc. So me, I'm my own candidate in that respect, and since started focusing more on eating the tree oils, Professor Kosa's story has worked for me. So I think that that is something.
Permission, I want to say something about what he said. So it's a very controversial topic. Sometimes it comes across as if it's a battle between the pharma industry and the food industry. Who is superior, who can market more? But as I stand here, I'm on the side of the farmer on this one. Not because I believe them so much, but that's where the evidence is. That can be shown. And it is clear from all the data that statins really saves lives. I'm not saying that eating the canolas and the plant vegetables or oil may not, but the evidence is not as robust. So maybe going forward, that side of argument probably get to the wheels and show us more data for us to show. And really, what you eat matters, but if you look at the contribution of diet to cholesterol levels in your body, it's just about 15 to 20%. And a lot of it, a lot of the reasons for dyslipidemia is really not about what you eat. They are inborn. The graph that I think Mr. Palu showed about how statins work, the pattern of dyslipidemia, there are various things that can go wrong along that path that ultimately leads to dyslipidemia. Many people would say, I don't eat oil, I don't eat fat, I don't do this. They are thin, unlike me, yet they have high cholesterol levels. So it goes beyond diet. And it is shown that it saves life. So I will not fight anybody, but I just say I'll go with my evidence. Show me your evidence, and we can meet somewhere and talk. But let's keep our questions short because we are running out of time. Thank you.
Thank you very much. Any more questions? Yes, for all the talks that we've had, for all three, yes. If there are any more questions. In-house. Okay, there are no questions online too, so I think yes.
Thank you all for coming, and then for those of you online, we've had a very educative evening. We started with acute complications, and we found out that hypoglycemia is more serious. Its complications being falls and fractures, seizures, strokes, unexplained death, and various patients react differently to low glucose levels. Hypoglycemic unawareness in long-standing diabetic patients, so please be aware of that. Then we came to chronic complications, and we spoke about microvascular. And it's important that we do early screening up to detect diabetic nephropathy, since kidney failure is 10 times more common in diabetic patients. Eye exam, we don't often send our patients, but in the type 2 diabetic, as soon as the sugar is well controlled, they should go for ophthalmological exam. And in the type 1, 5 years after diagnosis. Peripheral artery disease, Dr. Adai talked about. How often do we examine the feet of our patients when they come to our clinics? Very rare, because of course most of them have smelly feet, sorry to say that, and then we don't want to touch them. But please, at least educate them what they should wear, clean their feet, how they cut their toenails. And we've also got to learn about people with diabetes suffer more from depression, and that mental patients have more diabetes. And that when you have mental illness, it increases your risk of diabetes and diabetes complications. And we've gone through a whole lot how to screen them and all that. So the evening is well spent. We've learned a lot. I don't know whether the slides will be available, but we'll see what we can do. So thank you all for coming, and have a good night. Dinner will soon be ready.
Okay, thank you all very much. Dinner is almost served. Please, we are reminded that tomorrow morning at 6 o'clock we are meeting at Aimensa toll booth. Yeah, so you can enjoy your dinner, eat everything, come and burn it off tomorrow morning. It will be an 8K walk, so we're going up the hill, maybe about 5, and then